Welcome to Autism Across the Lifespan, evidence-based update. Autism spectrum disorder, or ASD, is now recognized as a lifelong neurodevelopmental condition that shapes how a person perceives, communicates, moves, and participates across every setting of daily life. Current United States surveillance data report a prevalence of approximately 1 in 36 children and an estimated 2.21% of adults, roughly 5.4 million US adults, with ongoing increases driven largely by improved recognition among girls, women, adults, and historically underidentified racial and ethnic groups. Physical therapists, occupational therapists, nurses, and other allied health professionals encounter autistic people in early intervention programs, schools, primary care clinics, inpatient hospitals, outpatient rehabilitation, mental health services, vocational programs, and geriatric settings. Yet surveys consistently show that most clinicians complete training with limited contemporary autism content. Many autistic patients report that their healthcare experiences are marked by sensory overload, communication mismatches, misattribution of distress, and diagnostic overshadowing, which is the misattribution of co-occurring symptoms to the autism diagnosis itself. This course brings together the most clinically relevant peer-reviewed evidence published between 2022 and 2026, along with current US practice guidelines from the American Academy of Pediatrics, the American Academy of Family Physicians, the American Occupational Therapy Association, and the American Academy of Child and Adolescent Psychiatry. We've organized the course around the lifespan, from early identification and the DSM-5-TR diagnostic framework through sensory, motor, and communication differences co-occurring physical and mental health conditions, premature mortality, early childhood and school-age interventions, adolescent transition, vocational supports, and autism-affirming adult healthcare using the SPACE framework and the Autism Healthcare Accommodations Tool, known as the AHAT. Throughout the content, the neurodiversity paradigm, identity-first language, camouflaging, autistic burnout, sex and gender-related diagnostic disparities, and interprofessional collaboration models are woven into each clinical topic rather than isolated in a single module. The course is designed to translate dense and sometimes conflicting recent evidence into actionable interprofessional practice. Research findings are presented throughout with enough clinical context for you to weigh the strength, direction, and practical relevance of the evidence rather than rely on summary impressions alone. At completion, you should be prepared to recognize autism across diverse presentations, communicate in autism-affirming ways, screen and refer appropriately, deliver evidence-based interventions, anticipate co-occurring conditions, and collaborate across disciplines to improve health, participation, and quality of life for autistic people of every age. Before we begin, let's review the learning objectives for this course. Upon completion, you'll be able to define the DSM-5-TR diagnostic criteria and severity levels for autism spectrum disorder, describe the neurodiversity paradigm and its influence on clinical communication with autistic individuals, identify validated screening and diagnostic tools for autism across pediatric and adult populations, recognize core sensory, motor, and communication differences commonly observed in autistic individuals, list common co-occurring physical and mental health conditions associated with autism spectrum disorder, explain evidence-based early childhood and school-age interventions for autistic children, and state the key principles of adolescent transition planning and autism-affirming adult healthcare. With those objectives in mind, let's get started with our first module. Module 1 is titled Foundations, DSM-5-TR Criteria, Epidemiology, and Etiology. We'll begin with the diagnostic framework. The American Psychiatric Association's Diagnostic and Statistical Manual of Mental Disorders, 5th edition, text revision, referred to as the DSM-5-TR, defines autism spectrum disorder as a neurodevelopmental condition requiring persistent impairment in 2 symptom domains that are present from the early developmental period and that cause clinically significant functional impairment. Criterion A requires deficits in social communication and social interaction manifested across all 3 subdomains: social emotional reciprocity, such as abnormal social approach, failure of back and forth conversation, or reduced sharing of interests or emotions; nonverbal communicative behaviors, such as poorly integrated verbal and nonverbal communication; differences in eye contact, body language, and gesture use; and development, maintenance, and understanding of relationships, such as difficulties adjusting behavior to social contexts, imaginative play, or making friends. Criterion B requires at least 2 of 4 restricted, repetitive patterns of behavior, interests, or activities, stereotyped or repetitive motor movements, use of objects or speech, insistence on sameness or inflexible adherence to routines, highly restricted, fixated interests, abnormal in intensity or focus, and hyper or hyperreactivity to sensory input or unusual sensory interests. Symptoms must be present in early development, which is criterion C. They must cause clinically significant impairment, which is criterion D, and they must not be better explained by intellectual disability alone, which is criterion E. The DSM-5-TR requires clinicians to specify severity separately for each symptom domain on the basis of the degree of support the individual requires in daily life. Level 1 requiring support, Level 2 requiring substantial support, and Level 3 requiring very substantial support. Recent validation work has demonstrated that clinician-assigned support levels correspond meaningfully with standardized assessment outcomes and are associated with intellectual functioning, adaptive functioning, and autism symptomatology, but not with sex assigned at birth. The DSM-5-TR explicitly discourages imprecise functioning descriptors such as high functioning and low functioning, because these labels fail to capture the uneven support profile that's typical of autism. Additional specifiers document whether the presentation occurs with or without accompanying intellectual impairment, with or without accompanying language impairment, and whether there's association with a no medical or genetic condition. The term profound autism, introduced by the Lancet Commission to describe autistic individuals with minimal verbal communication and significant intellectual disability who require 24-hour care, isn't a formal DSM-5-TR specifier or diagnostic category. The transition from DSM-5 to DSM-5-TR involved text clarifications and renewed emphasis on clinical judgment rather than substantive changes to the core criteria. The September 2025 DSM-5-TR text update expanded guidance on sex and gender-related differences and on camouflaging, noting that females and gender-diverse individuals may go unrecognized because of subtler symptom expression and compensatory strategies that mask core features in social contexts. Let's look at which diagnostic criteria carry the most weight when assessing adults. Whaling and colleagues in 2025 evaluated which DSM-5-TR criterion domains carried the most diagnostic weight among adults referred for autism assessment. They found that social-emotional reciprocity was the single strongest predictor of an autism diagnosis, carrying far greater diagnostic weight than any other criterion, and that nonverbal communication was nearly as powerful a predictor. Relationship differences followed as a moderately strong predictor, need for routines showed a weaker but still meaningful contribution, and stereotyped or repetitive behaviors contributed the least predictive weight among the significant domains. Intense interest and sensory processing differences added limited incremental predictive value over core social communication features. Sex assigned at birth didn't meaningfully enhance diagnostic prediction once core symptom presentation was considered. These findings support clinician focus on the social communication triad, while still documenting restricted, repetitive, and sensory differences, and they argue against reliance on sex-based heuristics that contribute to under-identification of autistic women and girls. Now let's look at the epidemiology, beginning with United States and global prevalence data. The most recent Centers for Disease Control and Prevention, Autism and Developmental Disabilities Monitoring Network Surveillance, known as ADDM, covering the 2020 year, and published in 2023, reports an overall ASD prevalence of approximately 1 in 36 among children aged 8 years across 11 US sites. Autism was approximately 3.8 times as prevalent among boys as among girls, a notable decline from the 4.5 to 1 male-to-female ratio reported in 2012. Suggesting improved identification of autistic girls over time. For the first time in ADDM surveillance history, prevalence was lower among non-Hispanic white children than among non-Hispanic Black, Hispanic, and non-Hispanic Asian or Pacific Islander children, reversing a pattern that had persisted across all prior surveillance cycles and pointing to expanded identification in communities that were previously under-recognized. Geographic variation was substantial, with nearly a twofold difference between the lowest prevalence site in Maryland and the highest in California. Among children aged 4 years in 2020, overall prevalence was lower than among 8-year-olds, with site-specific rates ranging from Utah at the lowest to nearly 4 times higher in California, reflecting wide regional differences in how early identification systems function. Grosvenor and colleagues in 2024 analyzed a large, diverse US health system population from 2011 to 2022 and found that diagnosis rates rose approximately 175% over that period, with the steepest relative increases occurring among young adults and females. This suggests substantial catch-up diagnosis rather than a uniform rise across ages. Among adults aged 26 to 34 years, diagnosis rates increased approximately 450% over the study window, and the male-to-female ratio declined steadily across calendar years. Parent-reported National Health Interview Survey. Data estimated ASD prevalence among US children and adolescents aged 3 to 17 years at roughly 3.4% over 2021 and 2022. higher than the ADM surveillance figure because it captures parent-identified cases. Global estimates are lower. The Global Burden of Disease Study 2021 placed worldwide ASD prevalence at 1 in 127, substantially higher than the Global Burden of Disease 2019 estimate of 1 in 271. That change was driven largely by methodological refinements that excluded passive case-finding studies. The global age standardized sex ratio was 2.1 to 1, lower than the US ratio, and reflecting persistent worldwide underrecognition of autistic women and girls. A separate global burden of disease analysis across 204 countries from 1990 to 2019 found that age-standardized estimates remained broadly stable globally, but that both prevalence and overall disease burden, which combines years lost to premature death with years lived with disability, increased in high socio-demographic index countries. This is consistent with changes in who gets identified rather than a biological change. The gap between the US figure of 1 in 36 and the global figure of 1 in 127 is best explained by differences in case ascertainment methods, diagnostic practices, and service availability. Turning now to adult prevalence and demographic disparities, population-based modeling suggests approximately 2.21% of US adults aged 18 years and older have ASD, including both diagnosed and undiagnosed cases, a figure that was remarkably consistent across states and across different modeling assumptions. That corresponds to roughly 5.4 million US adults. The DSM-5-TR itself reports ASD frequencies of 1 to 2% across US child and adult samples. A 2023 Medicaid claims analysis of 403,028 unique adults with autism claims from 2011 to 2019 found that autism prevalence more than doubled over that period, with the largest increase, 195%, occurring in the 25 to 34 age group. This strongly suggests that many older autistic adults remain undiagnosed. Timing of diagnosis and equity and identification remain active concerns. The median age of earliest known ASD diagnosis among 8-year-olds in the 2020 ADM data was 49 months, or approximately 4 years and 1 month, with site-specific variation from 36 months in California to 59 months in Minnesota. Children with co-occurring intellectual disability were diagnosed earlier, at a median of 43 months, than those without, at a median of 53 months. You and colleagues in 2024 reported a median diagnostic age of 3.53 years, with the middle half of children diagnosed between roughly 2.5 and 5.5 years, within a health-insured population, and demonstrated that higher neighborhood disadvantage at birth was associated with a small but statistically reliable increase in the likelihood of ASD diagnosis for each step up the disadvantage scale. This suggests that socioeconomic context shapes both biology and ascertainment. Intersectional analyses have shown persistent diagnostic delays for girls, particularly those who are non-Hispanic white, Black, or Asian, and that Black children are more likely to present with co-occurring intellectual disability and are diagnosed earlier when intellectual disability is present but later when it isn't. An important question for clinicians is why autism diagnoses have risen so dramatically. The majority of the rise over the last 2 decades is attributable to diagnostic practice changes, broadened criteria, expanded awareness, and improved access to evaluation services, not to a true underlying increase in incidence. Liao and Fonbon in 2026 synthesized contemporary surveillance and argued that current prevalence figures, particularly at the upper end of US estimates, reflect diagnostic overdiagnosis and over-identification of milder presentations that wouldn't have met earlier thresholds. This interpretation fits with the observation that the proportion of diagnosed individuals with co-occurring intellectual disability has fallen substantially over the past 40 years, from roughly 70% to 30%. That tells us contemporary cohorts include a much broader range of presentations than early cohorts did. From the clinician's standpoint, the practical implication is that the condition being diagnosed in 2026 isn't identical to the condition diagnosed in 1986, and that educational and service system planning must account for the heterogeneity of presentations captured under the current DSM-5-TR framework. Before we leave epidemiology, let's highlight motor milestone delays as a prevalent epidemiologic signal in autism. Pekoski and colleagues' 2025 AD-DDM linked analysis of 32,850 autistic 8-year-olds found that 71.4% met criteria for motor milestone delays. Population-level estimates range from 35 to 88% depending on the measure, with cascading effects on play, participation, and social engagement that remain dramatically under-recognized in clinical care. We'll examine motor differences, their clinical assessment, and evidence-based intervention in detail when we reach Module 4. Now let's explore the etiology of autism, beginning with genetic architecture. Autism spectrum disorder is among the most heritable psychiatric conditions, with twin and family studies converging on heritability. Estimates of approximately 80%, a figure that has been replicated with high consistency across multiple twin and family studies, and environmental factors accounting for roughly 14 to 22% of population risk. The genetic architecture involves multiple layers. Most cases are polygenic, involving hundreds of common variants of small individual effect, while rare high-impact variants, including de novo or newly arising single nucleotide variants and copy number variants, which are deletions or duplications of DNA segments, are implicated in approximately 2 to 4% of cases and are often associated with syndromic presentations. Key autism-associated genes converge on synaptic and neurodevelopmental pathways. SHANK3 encodes a postsynaptic scaffolding protein, which is a molecule that organizes signaling at the junction between nerve cells. CHD8 regulates chromatin structure during neurogenesis, influencing how genes are read during brain development. And MECP2, associated with Rett syndrome, participates in transcriptional regulation, controlling which genes are turned on or off in the brain. Antaki and colleagues in 2022 demonstrated that the genetic loads of rare and polygenic risk are inversely correlated within cases and are greater in autistic females than in autistic males. This finding is consistent with the female protective effect and with a liability threshold model, which is a statistical framework proposing that a condition manifests only after cumulative risk factors exceed a certain level. In this model, females require a higher genetic burden to manifest an autism phenotype, meaning the observable set of autistic characteristics. Genetic risk for ASD overlaps substantially with risk for schizophrenia, attention deficit/hyperactivity disorder, and intellectual disability, reinforcing the idea that autism sits within a broader neurodevelopmental constellation rather than as an isolated category. Continuing with etiology, let's look at the neurobiology and environmental contributions. Contemporary imaging research reveals altered connectivity in large-scale brain networks, including the default mode network, which is active during internal thought, the salience network, which prioritizes relevant stimuli, and the social brain networks, which process social information. These differences emerge before behavioral diagnosis. Structural neuroimaging studies have documented differences in cortical thickness, surface area, and patterns of early brain overgrowth, followed by partial normalization. Functional studies point to excitatory inhibitory signaling imbalances, a disruption in the normal balance between nerve signals that activate and those that calm neural circuits that may contribute to sensory processing atypicalities and social communication differences. Despite these advances, no single biomarker has achieved clinical utility for ASD diagnosis, and clinical identification remains behaviorally anchored. Environmental risk factors are real, but individually small. Advanced paternal age is associated with an approximately 21% increase in ASD diagnosis per 10-year increment, most likely through accumulation of de novo mutations in the paternal germline. Maternal age of 35 years or older is also associated with a modest but reliably replicated increase in risk, roughly 30% above baseline. Prenatal exposures including valproic acid, which carries an absolute risk of autism of 4.4% in exposed pregnancies versus 1.5% in unexposed maternal immune activation, gestational hypertension, and preeclampsia are established contributors. A large and methodologically diverse body of research definitively refutes any causal linkage between vaccines and autism. This is among the most rigorously examined questions in modern epidemiology, and clinicians should counsel families accordingly. Let's close Module 1 with 4 clinical anchor points that the rest of the course will build on. First, DSM-5-TR criteria are behavioral and multi-domain, and severity levels describe support needs per domain rather than global functional labels. Second, epidemiology has shifted. US prevalence is now 1 in 36 in children and approximately 2.21% in adults, with narrowing male to female ratios that reflect better identification of females rather than changing biology. Third, the most rigorous contemporary synthesis attributes rising diagnosis rates primarily to diagnostic practice change and milder presentation capture, rather than to a true rise in incidence. And fourth, autism is highly heritable with a polygenic plus rare variant architecture, a multi-network neurobiology, and well-established prenatal risk factors, while vaccines are definitively not among those factors. Now let's turn to Module 2, which focuses on the neurodiversity paradigm and clinical communication. This module will ground you in the conceptual shift that's reshaping how allied health professionals think about autism, and it'll give you concrete guidance on language, goal setting, and recognizing key phenomena like camouflaging and autistic burnout. We begin with the shift from the medical model to the neurodiversity framework. How we think about autism has changed in a fundamental way, moving from a deficit-based medical model toward a neurodiversity-affirming framework that recognizes autism as a form of human neurological variation rather than solely a disorder requiring cure or normalization. The traditional medical model locates disability within the individual and focuses on reducing the outward manifestations of neurodevelopmental difference. The neurodiversity paradigm, by contrast, treats neurological and developmental differences as part of the normal range of human variation, and argues that many of the challenges autistic people face arise from misalignment between autistic characteristics and societal expectations rather than from inherent pathology. Pelicano and Den Houting, writing in 2022, argue that polarizing these two perspectives as mutually exclusive actually impedes progress. Instead, they propose a duality view that creates common ground for medical, psychological, social, and environmental interventions aimed at alleviating distress and improving adaptive functioning and quality of life. Chapman and Botha, in 2023, extend this further by describing neurodivergence-informed therapy, a stance in which clinicians acknowledge neurotype-based disadvantage while still providing targeted support, rather than treating autistic traits themselves as a therapeutic target. For allied health clinicians, the practical implication is a reorientation of clinical focus, from attempting to eliminate autistic traits toward optimizing the fit between the person and their environment. This reframe shows up in practice through environmental adjustments, communication scaffolding, sensory modifications, and goals that reflect what autistic patients and their families themselves prioritize, rather than what clinicians presume they should want. Next, let's talk about one of the most visible aspects of this shift, language, specifically the choice between identity-first and person-first language. Language preferences among autistic people are varied and context-dependent, and there's no universal consensus. However, a 2025 systematic review by Schock and colleagues, covering 19 studies with a combined sample of 6,350 participants, found that more autistic adults preferred identity-first language, meaning the phrasing autistic person than person-first language, meaning the phrasing person with autism. That said, 4 to 39% of respondents endorsed person-first language, and 4 to 37% expressed no preference. A 2023 United States stakeholder sample by Taboas and colleagues added further nuance. Autistic adults in that study, numbering 299, overwhelmingly preferred identity-first language, while professionals, numbering 207, were more likely to support person-first language. This gap matters because it reflects a mismatch between community and professional norms, rather than a settled question. Berry and colleagues, also in 2023, further showed that stronger autism identity correlates with preference for identity-first language, whereas greater internalized stigma correlates with finding identity-first language less preferable and more offensive. In other words, language use is entangled with identity and the experience of stigma. Several professional organizations have weighed in. The American Occupational Therapy Association's 2024 practice guidelines for autistic people across the lifespan explicitly endorse identity-first language. American Family Physician noted in its 2025 primary care review that clinicians are less likely than autistic people themselves to use identity-first terminology and recommended aligning language with patient preference. The practical clinical recommendation that emerges from this evidence is straightforward. Ask each patient their language preference, honor it in the chart and verbally, and when preference is unknown, default to identity-first language because it's favored by the majority of autistic adults in contemporary samples. Now let's move to how the neurodiversity paradigm changes goal setting and clinical interventions. The neurodiversity paradigm requires a reorientation of intervention goals away from symptom reduction and toward outcomes that autistic people themselves prioritize. Lerner and colleagues, writing in 2023, argue that goals aimed at reducing or eliminating autism symptoms are, in their words, practically and ethically incompatible with a neurodiversity perspective, and that affirming interventions instead target functioning, autonomy, well-being, and environmental fit. Nicolaides and colleagues in 2025 put this shift into practice empirically, using a community-based participatory research nested Delphi process. For those unfamiliar, this is a structured consensus method embedded within a research partnership that includes community members. Their process involved 53 experts, including autistic adults, family members, providers, and researchers, who worked to identify high-priority outcomes for evaluating services for autistic adults. The consensus outcome list included quality of life, overall health and emotional well-being, anxiety, depression, and suicidality. Autistic burnout treated as a distinct construct from depression, social support and community participation, employment satisfaction, self-determination, access to communication, activities of daily living, and satisfaction with services. Reducing autistic traits wasn't prioritized by any stakeholder group. This outcome framework has direct implications for physical therapy, occupational therapy, and nursing practice. Rather than writing goals that aim to reduce stimming, suppress special interests, enforce eye contact, or normalize conversational style, clinicians are asked to anchor goals in the patient's own priorities. These might include participating in a chosen activity, moving through a sensory environment with less distress, communicating wants and needs reliably, maintaining employment, or navigating a healthcare encounter without overload. Pantazakos and Vanaken, writing in 2023, frame this transition as a phenomenological reorientation in which the autistic person's own lived experience becomes the primary reference point for both assessment and treatment planning, rather than the clinician's external judgments of normality. Project AIM, a large meta-analysis of early childhood autism intervention studies, similarly cautioned that many conventional intervention effect sizes are driven by outcomes selected by researchers rather than by outcomes that autistic people and families identify as meaningful. That reinforces the need for autism-prioritized goal setting, even in evidence-based early intervention. In practice, this reorientation doesn't eliminate the clinician's expertise, it repositions it. The physical therapist still assesses gait, coordination, and postural control, but uses that assessment to support functional mobility goals the patient values, not to impose a neurotypical movement aesthetic. The occupational therapist still conducts sensory and participation analyses, but reframes apparent non-compliance as a signal that an environment or demand exceeds the person's current regulatory capacity, not as a behavior to be eliminated. The nurse still performs health assessment, medication reconciliation, and patient education, but does so using communication accommodations, sensory modifications, and consent practices that honor autistic ways of processing information. Hilton and colleagues in 2023 demonstrated that sensory social communication and behavioral factors are major predictors of participation difficulties among autistic children, and that interventions addressing environmental barriers rather than individual deficits produce more durable functional improvements. Across disciplines, the neurodiversity-affirming stance is both an ethical commitment and a pragmatic one. It aligns treatment targets with outcomes the patient actually values and will sustain. Now let's turn to two important and interrelated phenomena: camouflaging and autistic burnout. Camouflaging refers to behaviors and strategies that autistic people use to mask autistic features in social contexts in order to appear non-autistic, creating a mismatch between what others see and what the person is actually experiencing. Autistic females report significantly more camouflaging across all domains, including assimilation, which means blending in by adopting others' behaviors, compensation, which involves developing strategies to overcome social communication difficulties, and masking, which is hiding autistic characteristics. Compared to autistic males, females engage in more of all three. Late diagnosed adults also report more camouflaging than those diagnosed earlier. Klein and colleagues, in a 2025 systematic review of social camouflaging in autistic adults and youth, identified self-protection and desire for social connection as core motivators. Zhuang and colleagues in 2023 performed a mixed-method systematic review of 58 studies and 4,808 participants and found that camouflaging is primarily a socially motivated response that carries consistent psychosocial costs. Those costs include being overlooked and under-supported clinically, post-interaction exhaustion and burnout, strained social relationships, reduced self-esteem, and identity confusion. Autistic burnout is a related but distinct construct. Ali and colleagues in 2025 conducted a systematic review and characterized it as involving pervasive exhaustion, social and occupational withdrawal, cognitive difficulties, reduced capacity for daily living skills, and an increased surfacing of autistic traits. These symptoms can be mistaken for depression, but respond to different supports. Addressing burnout, according to the synthesized evidence, requires individual coping strategies, clinical recognition including distinguishing burnout from depression, and broader societal and workplace acceptance of autistic ways of being. For clinicians, this means that when an autistic patient presents with fatigue, withdrawal, declining function, or sudden loss of previously mastered skills, the differential should include autistic burnout, not only depression or regression. Management should include reducing social and sensory demands, restoring access to special interests and restorative routines, and pacing participation rather than pushing for increased output. Let's look now at where major professional organizations stand on these issues. Several major United States professional organizations have articulated positions aligned with the neurodiversity paradigm. The American Occupational Therapy Association's 2024 practice guidelines for autistic people across the lifespan explicitly endorsed neurodiversity-affirming practice, recommending strengths-based language, environmental adaptations, and participatory approaches in which autistic people help define their own goals. Recent American Journal of Occupational Therapy publications have also adopted identity-first language out of respect for community preferences and in alignment with anti-ableist language recommendations. The American Academy of Family Physicians' 2025 Primary Care Review explicitly discusses the neurodiversity paradigm and chose to use identity-first language throughout, explaining that doing so respected the self-advocate perspective. In pediatric medicine, the American Academy of Pediatrics has increasingly emphasized shared decision-making and family collaboration in evaluation and choice of interventions, and a 2023 JAMA clinical review similarly endorsed person-centered, neurodiversity-informed primary care practice. By contrast, no specific autism-affirming practice statement has been identified from the American Nurses Association or the American Physical Therapy Association within the 2022 to 2026 literature. This is a gap that clinicians in those professions should be aware of when seeking guidance. Now let's address some common myths about autism and the evidence-based corrections that allied health professionals should be prepared to deliver. The first myth is the claim that autistic individuals lack emotions or can't form relationships. Extensive evidence of deep emotional experience and relational capacity contradicts this, including the community-prioritized outcomes identified by Nicolaides and colleagues, which explicitly centered relationship quality and community participation. The second myth is the conflation of autism with intellectual disability. Although a substantial minority of autistic children have co-occurring intellectual disability, the majority don't. And this proportion has fallen substantially over recent decades as milder presentations have been recognized. The third myth is the vaccine-autism linkage, which has been thoroughly refuted across large-scale epidemiologic studies and should be named plainly as disproven. The fourth myth is that autism is a childhood disorder that can be outgrown. In reality, it's a lifelong condition whose presentation changes across development, and the neurodiversity paradigm explicitly reframes adult autistic experience as central rather than peripheral. Several additional misconceptions are especially relevant to rehabilitation and nursing practice. First, the belief that behavioral interventions are universally effective and free of harm isn't supported by the current evidence base. Community-engaged synthesis work highlights participant-reported adverse experiences, including post-traumatic symptoms and camouflaging-related harms, particularly when interventions target suppression of autistic traits. Second, the belief that sensory processing differences are peripheral is contradicted by their inclusion as core diagnostic features, and by the consistent finding that sensory regulation profoundly shapes participation across the lifespan. Third, the assumption that nonverbal or minimally verbal individuals lack receptive language is both inaccurate and clinically harmful. Clinicians should presume competence, speak to the person directly, and ensure access to augmentative and alternative communication, often referred to as AAC. And fourth, the assumption that person-first language is universally preferred is contradicted by current systematic review evidence showing that identity-first language is preferred by the majority of autistic adults. Let's close Module 2 with the key clinical takeaways for physical therapists, occupational therapists, and nurses. This module establishes 3 practical foundations that shape every subsequent clinical encounter. First, the neurodiversity paradigm doesn't require abandoning clinical identification, treatment, or support. It requires reorienting their purpose from trait reduction to person-environment fit and autistic prioritized outcomes. Second, language choice isn't cosmetic. Ask each patient their preference, default to identity-first language when that preference is unknown, and recognize that many autistic people experience person-first language as stigmatizing even when it's well-intended. And third, camouflaging and autistic burnout are real, measurable phenomena with significant clinical consequences. Recognizing them changes both assessment by asking what the patient is actually experiencing beneath observed behavior, and treatment planning by asking how we reduce demand and restore regulation rather than escalate participation. With these foundations in place, we're ready to move forward into the clinical content that builds on them in the modules ahead. Moving into Module 3, we turn our attention to one of the most consequential aspects of autism across the lifespan: how autism is identified, diagnosed, and how sex and gender considerations shape that entire process. This module traces the identification pathway from universal pediatric screening all the way through adult evaluation, with particular attention to the sex and gender-related disparities that delay diagnosis for many individuals. Let's begin with pediatric screening and the framework recommended by the American Academy of Pediatrics, or AAP. Current United States pediatric primary care practice is built on a 2-layered model of developmental surveillance and structured screening. This was reaffirmed in the AAP's 2020 clinical report on identification, evaluation, and management of children with autism spectrum disorder, and in subsequent primary care syntheses. Developmental surveillance is continuous and embedded in every well child visit from birth through adolescence. It incorporates elicited parental concerns, focused developmental history, direct clinical observation of social communication and motor behaviors, and review of milestone attainment against the 2022 CDC AAP family-friendly milestone checklist, which was revised to a 75th percentile threshold to improve sensitivity. Structured universal developmental screening is recommended using validated tools at the 9-month, 18-month, and 30-month well child visits, with autism-specific screening at the 18-month and 24-month visits. Any positive or concerning screen should prompt referral to Part C early intervention for children under 3 years, or to school-based special education services for children aged 3 and older. The United States Preventive Services Task Force has concluded that evidence is insufficient to recommend universal ASD screening in asymptomatic children, citing a lack of randomized trials linking screening directly to improved outcomes. Nevertheless, the AAP continues to recommend universal screening on the basis of expert consensus and the documented benefits of early intervention, and most US primary care pediatricians follow the AAP pathway. Now let's look at the specific validated tools used in pediatric screening. The modified checklist for autism in toddlers, revised with follow-up, known as the MCHAT-RF, is the most widely used autism-specific screener for children 16 to 30 months of age. A 2023 JAMA Pediatrics meta-analysis of 50 studies by Wikowski and colleagues reported that the MCHAT-RF correctly identifies roughly 5 out of 6 autistic toddlers and has very high specificity, meaning very few non-autistic toddlers are incorrectly flagged. A parallel 2023 pediatrics meta-analysis by Ishwarya and colleagues found similarly high sensitivity at about 83%, but markedly lower specificity, meaning the tool correctly identifies most autistic toddlers but flags a substantial number of non-autistic children as well. Real-world electronic health record implementation studies have reported sensitivities as low as 39%, with worse performance among girls, children of color, and children from lower-income households. This finding has direct equity implications for how clinicians interpret a negative screen in a child whose family raises concerns. Here's a critical point. Children with a persistent positive MCHAT-RF carry a 47% risk of an eventual autism spectrum disorder diagnosis and a 95% risk of any developmental disorder. That means a positive screen, regardless of the ultimate ASD classification, should trigger a full developmental evaluation rather than reassurance. The Ages and Stages Questionnaire, 3rd edition, is a general developmental screener used across the 1 to 66-month age range. It has a sensitivity of approximately 77% and specificity of about 81% for detecting developmental delay overall, making it a reasonably reliable but imperfect general developmental screen. It's commonly paired with an autism-specific tool rather than used as a standalone ASD screener. The Social Attention and Communication Surveillance, revised, known as the SAXR, adds complementary capacity at the very young toddler range. Barbaro and colleagues' 2022 JAMA Network Open evaluation of SAXR in more than 13,000 Australian toddlers found sensitivity of 62% and very high specificity of 99.6% at 12 to 24 months, meaning it misses about 1/3 of autistic toddlers but almost never flags a non-autistic child. Sensitivity rose to 96% when the SX preschool tool was added at 42 months. So what does all of this mean in practice? Clinicians should understand screening not as a single visit test, but as a longitudinal process, serial surveillance, repeated screening across multiple visits, and responsiveness to parental concern combined to close the identification gap. A negative MCHAT-RF at 18 months doesn't preclude a later positive screen at 24 months. This is particularly true among girls and children whose presentations are dominated by internalizing features rather than overt restricted and repetitive behaviors. Now let's turn to the gold standard diagnostic workup. Beyond screening, the reference standard for ASD diagnosis remains a best estimate clinical consensus reached by a multidisciplinary team. This process integrates detailed developmental history, direct standardized observation, cognitive and adaptive functioning assessment, language and motor evaluation, medical and genetic evaluation, and systematic screening for co-occurring conditions. The Autism Diagnostic Observation Schedule, 2nd edition, known as the ADOS-2, and the Autism Diagnostic Interview Revised, known as the ADIR, are commonly incorporated as standardized structured components. However, neither is required for a DSM-5-TR diagnosis. Clinician judgment is explicitly privileged over tool classification, and combining the ADOS-2 with the ADIR hasn't been shown to meaningfully improve diagnostic accuracy over the ADOS-2 alone in contemporary clinical settings. Recommended ancillary assessments include cognitive testing using Wechsler scales, the Vineland Adaptive Behavior Scales, speech-language evaluation, and sensory motor assessment, along with screening for co-occurring intellectual disability, language disorder, attention deficit hyperactivity disorder, anxiety, and medical conditions that frequently accompany autism. The AAP and the American College of Medical Genetics and Genomics recommend that all newly diagnosed individuals undergo chromosomal microarray testing and Fragile X testing, with additional targeted genetic testing guided by clinical features such as facial dysmorphology, regression, or syndromic phenotype. Clinicians should verify current institutional and state-level protocols as genetic testing recommendations continue to evolve. There's also important evidence about how severity levels are used in practice. Gardner and colleagues in 2024 demonstrated that clinician-assigned DSM-5-TR support levels correspond meaningfully with standardized assessments of intellectual, adaptive, and autism-specific functioning. This provides empirical support for retaining severity level specification as part of the diagnostic record, even though those levels don't substitute for a full functional assessment and shouldn't be collapsed into global high-functioning or low-functioning shorthand. In contemporary US practice, the median age at which children in the ADDM surveillance network receive their earliest known ASD diagnosis is 49 months. There's substantial site-to-site variation and longer delays for children without co-occurring intellectual disability. This is a reminder that even well-functioning multidisciplinary systems leave multi-year gaps between parental concern and diagnostic confirmation. For allied health clinicians in early intervention and school settings, the practical implication is clear. Specialist referral shouldn't be deferred while waiting for a completed diagnostic evaluation. Consistent with AAP and American Occupational Therapy Association, guidance, evaluation, and intervention can and should run in parallel whenever clinical concern is present. Let's now discuss late diagnosis in adolescents and adults. A large lost generation of autistic adults remains undiagnosed. This is particularly true for those who grew up before contemporary diagnostic criteria were widely applied, and those whose presentations were subtler than the male childhood prototype on which most early research was built. Adult evaluation is typically prompted by persistent difficulties with social-emotional reciprocity, nonverbal communication, relationship maintenance, rigidity and reliance on routine, emerging or worsening anxiety or depression, occupational or educational breakdown, or by the recognition of autism in a family member, most commonly a child. Whaling and colleagues in 2025 found that among adults referred for autism evaluation, social-emotional reciprocity was the single strongest predictor of diagnosis, carrying far greater diagnostic weight than any other criterion. Nonverbal communication followed closely as nearly as strong a predictor. Relationship differences showed moderately strong predictive weight, need for routines contributed a weaker but still meaningful predictive signal, and repetitive behaviors contributed the least among the significant domains. Intense interests and sensory differences added limited incremental predictive value. Sex assigned at birth didn't meaningfully enhance diagnostic prediction once core social communication features were considered. Several self-report screening instruments support adult identification, though it's essential to understand that none of them are diagnostic on their own. The Autism Spectrum Quotient, 10-item version, known as the AQ10, is recommended by the United Kingdom's National Institute for Health and Care Excellence, or NICE, as a brief screen for adults without moderate or severe intellectual disability. It catches most autistic adults, with sensitivity of about 77 to 79%. But its ability to correctly rule out autism in non-autistic individuals is inconsistent across study settings, with specificity varying widely. The Ritvo Autism Asperger Diagnostic Scale, revised, known as the RADS-R, shows generally good performance across validation studies, with sensitivity ranging from 73 to 91% and specificity from 71 to 93%, reflecting considerable variation depending on the clinical population studied. However, in mixed adult mental health populations, where many non-autistic patients share overlapping features, overall diagnostic accuracy drops to a moderate level, with sensitivity of 75% and specificity of 71%. The Camouflaging Autistic Traits Questionnaire, known as the CATQ, quantifies assimilation, compensation, and masking behaviors, and is particularly valuable as an adjunct when evaluating women and gender-diverse adults whose presentations may not be well captured by tools developed on male samples. Clinicians should also be aware that widely used adult self-report instruments were validated on predominantly male, predominantly non-gender diverse samples. as newer tools such as girl-specific and female adult-specific questionnaires have been developed precisely because the conventional battery lacks content validity for autistic women and assigned female gender-diverse adults. Robinson and colleagues' 2025 analysis of 422 adult referrals found that simultaneous positive screens on 3 complementary measures, specifically the autism spectrum quotient, the empathy quotient, and an abbreviated CAST-RQ, identified autism with 98.3% likelihood in that clinical population, which was a high prevalence referral sample where 89% of individuals ultimately received an autism diagnosis. This result supports a multi-screen rather than single instrument strategy in adult workup, while reinforcing that no self-report instrument is standalone diagnostic. Digital behavioral phenotyping offers a complementary identification avenue as well. Perrichon and colleagues in 2023 reported strong overall diagnostic accuracy for an app-based toddler assessment, correctly identifying nearly 88% of autistic toddlers while correctly classifying about 81% of non-autistic toddlers, and the tool performs similarly across sex, race, and ethnicity. This suggests a role for technology-assisted identification that may help reduce disparities in access to evaluation. Now we turn to one of the most critical topics in contemporary autism research: sex and gender-related diagnostic disparities and the female phenotype. Underdiagnosis of autistic girls and women is one of the most consistently replicated findings in contemporary autism epidemiology. McIver and colleagues' 2026 Scottish clinical population analysis, which included 408 participants, found that females were referred for assessment approximately 5 years later than males, with a median age of 19.7 years versus 14.4 years. Females were also diagnosed approximately 5 years later, at a median age of 20.2 years versus 15.2 years. Among children and adolescents specifically, median age of referral was 10.5 years for females versus 7.5 years for males, and median age of diagnosis was 11.9 versus 9.3 years. Both of these differences were statistically significant and almost certainly not due to chance. The observed male-to-female ratio was 2.21 to 1 in children under 10 years, but this reversed to 0.79 to 1 in adolescence and 0.94 to 1 in adulthood. That tells us there's substantial childhood underdiagnosis that's only partially corrected through later identification. Consistent with these service data, the 2025 DSM-5-TR text update expanded guidance on sex and gender-related differences and on camouflaging, explicitly cautioning clinicians that females and gender-diverse individuals may be missed because of subtler symptom expression and compensatory strategies that mask core features in social contexts. Let's look more closely at what the female phenotype actually involves. The female phenotype, which is most pronounced in autistic individuals without intellectual disability, involves fewer observable restricted and repetitive behaviors, more socially normative special interests pursued with atypical intensity, better surface-level social communication, and greater internalizing symptomatology. Edwards and colleagues' 2024 meta-analysis documented that autistic males exhibit higher levels of stereotype behaviors, showing a small but consistent sex difference in the direction of higher male expression, and restricted interests with a similarly small but reliable difference favoring higher male expression, compared to autistic females. However, insistence on sameness and sensory differences don't differ significantly by sex. There's an important nuance here that clinicians need to keep in mind. Saw and colleagues' 2023 meta-analysis of 79 studies revealed a critical moderator. Among individuals with co-occurring intellectual disability, the sex difference pattern actually reverses. In this population, autistic girls and women show more social difficulties, more repetitive behaviors, poorer language, and more motor problems than boys. This is a reminder that generalizations about the female phenotype should be restricted to the without intellectual disability profile. Measurement bias compounds the clinical picture. Burrows and colleagues' 2025 JAMA network, open analysis of 4,550 children from the Baby Siblings Research Consortium, documented moderate measurement bias in the ADOS. Females were rated as less impaired than males on eye contact, response to joint attention, and quality of social overtures, even when underlying social communication difficulty was comparable. This reflects the fact that standard diagnostic instruments were developed on disproportionately male samples, and that thresholds don't currently adjust for sex. Camouflaging further erodes detection. McQuaid and colleagues in 2022 documented elevated camouflaging autistic traits questionnaire scores in autistic females across all 3 subscales, with particularly pronounced elevation among late diagnosed adults on the assimilation and compensation domains. So what should clinicians do with all of this? When encountering a possible autistic female, non-binary, or transgender patient, clinicians should consciously weight camouflaged or internalizing presentations, elicit developmental history across contexts, including home, school, peer, and workplace settings, and avoid defaulting to male prototype expectations of social communication behavior. Our final topic in this module is the post-diagnostic experience and the support gap that many adults face. Receiving an autism diagnosis in adulthood is frequently described as clarifying and self-compassionate. It reframes prior self-criticism as neurotype-based difference rather than personal failure. Keel and colleagues' 2024 qualitative metasynthesis of 24 studies characterized diagnosis as initiating a shift from a self-critical to a self-compassionate stance and as enabling access to community, language, and supports that had previously been inaccessible. Abu Ramadan and colleagues' 2025 United States survey of 129 autistic adults found that adult-diagnosed individuals were more likely than those diagnosed in childhood to have initiated evaluation themselves and to cite mental health concerns among their reasons for pursuing diagnosis. Gender-diverse respondents reported the highest number of diagnostic barriers and the greatest desire for post-diagnostic support around trauma and suicidality. The support side of the equation, however, is where contemporary systems fail most visibly. Norris and colleagues' 2025 United Kingdom systematic review of 19 studies concluded that most post-diagnostic support for adults consists of information provision and signposting rather than active psychoeducation, peer support, or practical accommodation. This leaves the majority of newly diagnosed autistic adults without access to the services they identify as most important. Adults themselves have articulated clear priorities: access to local peer support, professional training in adult autism, assistance processing the impact of late diagnosis, flexible modes of contact, and an individualized support plan that names specific follow-up steps rather than a generic handout. For allied health clinicians in primary care, rehabilitation, and mental health settings, the implication is practical and immediate. A diagnosis of autism in adulthood should trigger a coordinated response that includes plain language psychoeducation, validated resources, proactive screening, and management of the frequently co-occurring mental and physical health conditions addressed in later modules, referral to peer-led autistic community networks where available, and accommodations planning that's revisited at follow-up rather than treated as a one-time conversation. Before we close this module, let's address how intersectional disparities also shape the post-diagnostic experience. Gender-diverse autistic adults, in particular, report the greatest desire for targeted support around trauma and suicidality and the most barriers to accessing it. Racial and ethnic minority adults are overrepresented among those diagnosed later, with intellectual disability and after adverse mental health events rather than in the context of planned evaluation. The clinical takeaway is that post-diagnostic support isn't a courtesy offering. It's a core component of the Diagnostic Act and should be planned, documented, and resourced as such. With that, we conclude Module 3 on identification, diagnosis, and sex and gender considerations across the lifespan. In the modules ahead, we'll build on this foundation by examining the co-occurring conditions and support needs that emerge once a diagnosis is established. In Module 4, we shift our focus to sensory, motor, and communication differences. With the diagnostic framework established in earlier modules, we now examine the sensory, motor, and communication differences that define the daily clinical encounter with autistic patients. These are the features that shape how autistic individuals experience clinical environments, respond to intervention, and participate in daily life. Understanding them in depth is essential for any rehabilitation or nursing professional working with this population. Let's begin with sensory processing differences across the lifespan. Sensory processing differences are recognized as core diagnostic features of autism spectrum disorder under DSM-5-TR criterion B4 and are present in the large majority of autistic individuals across the lifespan, with population prevalence estimates ranging from 56% to 97%, depending on the subtype evaluated and the assessment method used, and with most contemporary large-scale pediatric studies reporting rates above 80%. Williams and colleagues' 2023 multi-site integrative data analysis of 3,868 autistic youth ages 3 through 18 across 12 datasets found strong evidence for 3 sensory reactivity domains: hyperreactivity, hyporeactivity, and sensory seeking, across visual, auditory, tactile, oral, and vestibular modalities. Hyperreactivity was the most reliably measured at the supramodal level, meaning across all sensory modalities combined, and the statistical reliability of the hyperreactivity measure was strong, confirming that it captures a coherent underlying sensory pattern rather than a collection of unrelated items. Lane and colleagues in 2022 used the Short Sensory Profile 2 in 919 autistic children ages 3 through 14 and found that sensory sensitivity and avoidance peaked in middle childhood, ages 6 through 12, while hyperreactivity and sensory-seeking behaviors remained comparatively stable across age cohorts. Females showed elevated sensory sensitivity relative to males, consistent with the female phenotype described in Module 3. These findings establish that sensory difference isn't a single trait, but a multidimensional profile that shifts with age and differs by sex. The clinical relevance of sensory processing extends well beyond sensory experience itself. Brandes Aitken and colleagues in 2024 identified 5 sensory processing subtypes in a mixed neurodevelopmental cohort and documented that sensory overresponsivity was distinctively associated with elevated anxiety scores, while sensory seeking and underresponsivity were linked to heightened attention deficit hyperactivity disorder scores. Across the full cohort, 39% met clinically concerning thresholds for emotion dysregulation, 19% for anxiety, and 62% for ADHD, showing just how tightly sensory profile is coupled with behavioral and emotional health. Chen and colleagues' 2024 systematic review and meta-analysis of 63 articles and 11,659 participants confirmed that hypersensitivity, visual, auditory, and tactile sensitivities were strongly associated with both internalizing problems such as anxiety, depression, and withdrawal, and externalizing problems such as aggression, hyperactivity, and conduct difficulties, while sensation seeking was strongly linked to externalizing behavior in particular. Sensory differences also have a developmental trajectory with downstream consequences. Longitudinal data show that infants and toddlers with greater sensory hyperreactivity go on to demonstrate more internalizing and externalizing problems, reduced participation, and lower adaptive functioning at school age, and that sensory hyperreactivity at 14 months predicts fearfulness at 24 months, and later social interaction and repetitive behavior profiles. These findings reframe sensory assessment from a single-point screen into a prognostic activity with implications for intervention planning. The practical clinical consequence of all this evidence is significant. Behaviors commonly labeled non-compliance, such as refusal, resistance to transitions, apparent oppositionality, and sudden emotional dysregulation, are frequently adaptive responses to overwhelming or aversive sensory input rather than intentional defiance. They should be reframed through a sensory lens before behavioral interpretation. Emotion dysregulation appears to mediate the pathway from sensory dysregulation to externalizing behavior in young autistic children. What that means in practice is that intervention targeted at environmental sensory load and at regulation skills often yields greater behavioral improvement than intervention targeted at the behavior itself. Validated clinical tools to support that sensory reframing include the Sensory Profile 2 and Short Sensory Profile 2 for school-age children, the Infant-Toddler Sensory Profile for children as young as 10 months, and the Adolescent-Adult Sensory Profile, or AASP, for self-report in individuals aged 11 and older. These instruments allow clinicians to stratify reactivity patterns across 4 quadrants. Low registration describes a high threshold with a passive response. Sensation seeking describes a high threshold with an active response. Sensory sensitivity describes a low threshold with a passive response. And sensation avoiding describes a low threshold with an active response. Using these quadrants, clinicians can tailor environmental and treatment recommendations accordingly. In adult practice, sensory processing challenges, particularly low registration and sensation seeking, remain prominent and partially mediate the relationship between attention and social responsiveness. This means that adult rehabilitation, mental health, and primary care encounters should be structured around sensory considerations such as lighting, auditory load, waiting room density, and exam pacing, rather than expecting the autistic adult to simply tolerate environments designed for neurotypical throughput. Now let's turn to motor differences and co-occurring developmental coordination disorder, or DCD. Motor impairment is one of the most prevalent and most under-recognized features of autism. Pekoski and colleagues in 2025 drew on 32,850 autistic 8-year-olds from the Autism and Developmental Disabilities Monitoring Network, known as the ADDM network, and found that 71.4% met criteria for motor milestone delays, and that the prevalence of autism with motor delays was 2.5-fold higher than the prevalence of autism without motor delays. The SPARK cohort analysis, SPARK standing for Simons Foundation Powering Autism Research for Knowledge, by Pat in 2020, used the Developmental Coordination Disorder questionnaire in 11,814 autistic children aged 5 through 15 years and reported that approximately 87 to 88% were at risk for motor impairment, a risk more than 20 times greater than that of the general population that persisted into adolescence. Yet only 31.6% of these children received physical therapy services. A 2024 systematic review and meta-analysis by Kangarani Farahani and colleagues confirmed that 50 to 88% of autistic children demonstrate significant motor impairment consistent with DCD, but only 15% of studies published after the 2014 DSM-5 recognized these difficulties under the DCD label, and only 15.1% of affected autistic children received a formal co-occurring DCD diagnosis. The clinical signal is clear. Motor difference is a near universal feature of autism in childhood. It's strongly linked to social communication, cognitive, and language severity, and it's dramatically underidentified and underserved in contemporary United States rehabilitation practice. Autistic motor impairments are broad in scope. A 2025 scoping review by De Silva and colleagues documented impairments across fine motor skills, including manual dexterity, handwriting, and precision tasks. Gross motor skills including running, jumping, and whole body movement. Balance and postural control. Coordination and praxis, which refers to the ability to plan and execute skilled movements including multi-limb coordination and motor sequencing. Gait, characterized by lower cadence, greater variability, and toe walking. Strength and ball skills, with intensification as children move into school age. The DSM-5-TR itself notes odd gait, clumsiness, and other abnormal motor signs, such as walking on tiptoes, as common associated features of autism, reinforcing that motor difference is an expected rather than incidental part of the clinical profile. These motor differences are functionally consequential. Wang and colleagues' 2022 meta-analysis of 114 studies comparing 6,423 autistic with 2,941 neurotypical individuals reported a large and clinically meaningful gross motor deficit, particularly pronounced for ball skills and object control, and a meaningful positive association between motor and social skill, such that children with greater motor impairment also tend to have greater social skill difficulties. This is consistent with the emerging view that motor coordination, executive function, and social communication develop in interdependent rather than parallel tracks. Pekoski and colleagues' ADDM-linked analysis further demonstrated that population-level estimates of motor impairment range from 35% to 88% depending on the measure, and that these motor differences have cascading effects on play, participation, and social engagement that are too often dismissed as peripheral to what we might consider core autism. Validated motor assessments relevant to clinical evaluation across rehabilitation and nursing settings include the Developmental Coordination Disorder Questionnaire, or DCDQ, which showed excellent internal consistency and concurrent and discriminant validity against the Movement Assessment Battery for Children. Second edition, known as the MABC2, in a 2022 autistic pediatric sample, along with high sensitivity paired with lower specificity that positions it as a screening rather than diagnostic instrument. The Vineland Adaptive Behavior Scales motor domain converges with DCDQ estimates at approximately 70% concordance and an 81.2% accuracy rate in the SPARC dataset. So clinicians using either instrument capture broadly similar delay rates, 82% on the DCDQ and 77% on the Vineland in the same sample. Measurement property syntheses indicate that many mobility instruments used in autism research have low to very low evidence quality, which means selection should be anchored to instruments with the strongest psychometric base and the most direct functional relevance. The American Academy of Pediatrics and Contemporary Rehabilitation Syntheses therefore recommend occupational therapy and physical therapy evaluation as part of the post-diagnostic workup, with approximately 2/3 of preschool children with autism requiring occupational therapy for motor, strength, and adaptive skills. That's a service access gap that rehabilitation professionals are positioned to close. BAT's 2024 SPARC analysis of service access showed that autistic children with motor challenges receive physical and recreational therapies at markedly lower rates than speech-language or conventional occupational therapy, even when their motor profile would clearly qualify them for physical therapy under community practice standards. Recognizing motor impairment is therefore not only a diagnostic task, but also a health equity task. Now let's look at the evidence for motor interventions and specific prescription parameters. Exercise and movement-based interventions produce consistently large effects in autistic pediatric populations. Feng and colleagues' 2026 meta-analysis of 16 studies with 493 children reported large and highly reliable improvements in balance, locomotor skills, and object control, all of comparable magnitude and all with strong statistical confidence that the effects are real and not attributable to chance. Land-based sports outperformed aquatic or technology-assisted modalities. Wu and colleagues' 2024 meta-analysis of 28 randomized controlled trials with 1,081 participants found a very large overall improvement in motor performance, along with meaningful reductions in restricted and repetitive behaviors and meaningful improvements in social functioning. That's evidence that motor-targeted interventions produce downstream improvements in core autism features rather than motor outcomes in isolation. Jin and colleagues' 2023 pilot randomized controlled trial of the Motion ASD occupational therapy protocol in preschoolers demonstrated superiority of Motion ASD over a conventional exercise comparator for manual coordination and overall gross and fine motor skills, with gains sustained at 4-week follow-up using a dosage of 30 to 60 minutes, 2 to 3 times per week for 8 to 12 weeks. Translating these findings into clinical prescriptions requires attention to dose. Atayed and colleagues' 2024 systematic review of exercise prescription for autistic individuals recommended aerobic exercise as most effective when delivered over 12 weeks, with 3 weekly sessions of 45 to 60 minutes. For muscle strength training, the recommendation is 2 sessions per week of 10 to 20 minutes each, with 2 to 4 exercises of 1 to 3 sets and 6 to 12 repetitions. Medium duration programs of roughly 1,440 cumulative minutes, equivalent to approximately 8 to 12 weeks of 345 to 60-minute sessions per week, emerged as the most consistent window in which measurable gains appear. Clinicians selecting between modalities should note that the evidence supports land-based, play-embedded programs more strongly than pool-based or technology-heavy approaches, and that visual instructional methods outperform purely verbal instruction for motor skill acquisition in autistic learners. These parameters fit naturally within existing pediatric physical therapy and occupational therapy service structures and should be communicated to caregivers and school teams so that prescribed dose can be protected from competing scheduling demands. The downstream effects of motor-targeted intervention extend beyond movement outcomes. Wu and colleagues' meta-analysis demonstrated meaningful reductions in restricted and repetitive behaviors and in social communication, dysfunction alongside motor improvement, suggesting that motor programs function as broad-spectrum interventions when delivered at adequate dose and with developmentally appropriate structure. The Motion ASD protocol's sustained gains at follow-up also show that motor change, once achieved, doesn't immediately wash out when formal sessions end. That's an important counter to the assumption that benefits require indefinite service delivery. Clinicians should, however, recognize the limits of the current evidence base. Most trials are short duration. Most are delivered in pediatric populations, and adult rehabilitation evidence remains comparatively thin. Extension of these parameters to adolescents and adults should therefore be accompanied by outcome measurement rather than simple generalization. Our final topic in this module is communication differences and augmentative and alternative communication, or AAC. Communication difference is a defining feature of autism and varies widely in both form and trajectory. The DSM-5-TR anchors the diagnosis in persistent deficits of social-emotional reciprocity, nonverbal communication and relationship development, and pragmatic language differences, meaning difficulties with the social use of language in context, are central to the clinical picture. This includes using language primarily to request or label rather than to comment, share feelings, or maintain reciprocal conversation. Approximately 1/3 of autistic children also have a co-occurring intellectual disability or minimal verbal ability, and up to 30% may never acquire functional verbal speech, though this proportion continues to evolve as earlier intervention becomes more common. McAllister and colleagues' 2025 analysis of 2,555 autistic youth ages 4 through 17 from the Simon Simplex collection found that echolalia, the immediate or delayed repetition of speech, is reported in up to 90% of autistic individuals at some point in development. Echolalia functions simultaneously as a communicative strategy and as a repetitive behavior, and it declines with age among individuals with higher verbal ability, while persisting as a communicative tool among adolescents with less generative speech. Prosodic differences, meaning atypical pitch, intensity, and rate, contribute to the perception of stilted or robotic speech in autistic speakers and are increasingly measurable using natural language processing methods that complement clinician-rated observations. Augmentative and alternative communication, or AAC, is a central evidence-based component of care for minimally verbal and emerging speech autistic individuals. The 2025 American Academy of Pediatrics Clinical Report on Prescribing Assistive Technology by Disic and colleagues explicitly states that AAC doesn't impede natural speech development and may in fact promote verbal expression and vocabulary growth, with evidence supporting AAC introduction in children as young as 9 months. This is a direct refutation of the persistent clinical myth that AAC delays speech. Pope and colleagues' 2025 systematic review and meta-analysis found that naturalistic developmental behavioral interventions, or NDBIs, produce strong effects on language development, and that effect sizes are notably larger when aided. AAC is incorporated within the NDBI procedure compared with NDBI alone. Speech-generating devices, or SGDs, have been shown to be superior to the picture exchange communication system, or manual sign language for building a requesting repertoire. Speech-generating device is incorporated into JASPER, which stands for Joint Attention, Symbolic Play, Engagement, and Regulation, a naturalistic developmental behavioral intervention discussed further in Module 6, combined with enhanced milieu teaching, have produced spontaneous verbal communication beyond requesting in school-age minimally verbal children. AAC relevance also extends well past childhood. A substantial proportion of autistic adults don't develop fluent spoken language, and communication barriers persist into adulthood, where they affect employment, healthcare access, and safety in emergencies. That makes AAC a lifespan intervention rather than a pediatric one. For rehabilitation and nursing clinicians, 4 operational principles follow from this evidence. First, presume competence. Speak to the person directly regardless of verbal status, because receptive language frequently exceeds expressive output, and because underestimation of comprehension is both ethically and clinically harmful. Second, advocate for early referral to a speech-language pathologist and for AAC evaluation rather than waiting for spoken language to emerge. The evidence that AAC helps rather than suppresses natural speech is now strong enough to reverse the old wait-and-see default. Third, ensure that AAC systems accompany autistic patients into physical therapy, occupational therapy, and nursing encounters across the lifespan, including adult healthcare and hospitalization, where the absence of a personal speech-generating device or communication board can render a patient functionally unheard, and where staff unfamiliarity with AAC devices can produce misattribution of confusion or non-compliance. Fourth, recognize echolalia as a potentially communicative behavior, rather than as noise to be eliminated. The Simon-Simplex data indicate that echolalia can function as a bridging strategy in adolescents with less generative speech, and clinicians who extinguish echolalia may inadvertently remove a working communicative tool. Taken together with the sensory and motor evidence reviewed earlier in this module, the communication literature reinforces the overarching message of this course. Autistic differences in sensation, movement, and communication are interdependent, measurable, and responsive to structured intervention, but they require clinicians who see them and who design care around them rather than against them. As we move forward, keep in mind that every clinical encounter is an opportunity to apply a sensory-informed, motor-aware, communication-supportive approach that respects and responds to the full profile of autistic experience across the lifespan. Module 5 addresses one of the most clinically important dimensions of autism across the lifespan: co-occurring conditions and premature mortality. The sensory, motor, and communication differences we examined in Module 4 don't occur in isolation. They interact with a broad range of co-occurring physical and mental health conditions that shape clinical outcomes throughout a person's life. In this module, we'll examine the physical health conditions that disproportionately affect autistic individuals, the mental health conditions that accompany autism at every age, the critical topic of suicide and self-harm risk, and the sobering data on premature mortality and reduced life expectancy. Each of these areas carries direct implications for how allied health clinicians screen, monitor, and support the patients they already serve. Let's begin with co-occurring physical health conditions. Autistic adolescents and adults experience elevated rates of chronic physical health conditions across virtually every organ system. This has direct implications for how allied health clinicians screen, monitor, and accommodate patients they already serve for other reasons. Ward and colleagues' 2023 analysis in molecular autism found significantly higher prevalence of non-communicable disease in autistic adolescents and adults relative to matched non-autistic peers. This elevated prevalence was documented across neurological, gastrointestinal, endocrine, cardiovascular, and musculoskeletal systems, with female autistic adults particularly affected by autoimmune and connective tissue conditions. Torenvliet and colleagues' 2025 Dutch comparison, which included 327 autistic and 274 non-autistic adults aged 30 to 90, reinforced that picture. Bowel conditions affected 27% of autistic adults, with odds ratios 2 to 4 times higher than non-autistic adults. The relative excess was larger, not smaller, in middle and later adulthood. The United States Primary Care Synthesis by Westby and Coburn-Pierce, published in 2025, identified diabetes prevalence at 7.5%, dyslipidemia at 22%, hypertension at 25%, allergies at 48%, constipation at 22%, and hypothyroidism at 6% among autistic adults. with motor coordination difficulties reported by 37%, which represents a roughly sevenfold increase over general population estimates. Epilepsy is the most clinically consequential neurological comorbidity. Approximately 1 in 10 autistic individuals has epilepsy, with prevalence rising substantially among those with co-occurring intellectual disability and among autistic females. Underwood and colleagues' Welsh population-level healthcare record study, which examined records of 3.6 million individuals between 2001 and 2016, documented a roughly ninefold increase in risk relative to the general population. Sleep disturbances are also critically important. They affect roughly 17% of autistic adults and up to 50 to 80% of autistic children. The primary care review by Westby and Coburn-Pierce highlights both the prevalence of sleep disturbances and their disproportionate contribution to behavioral dysregulation, suicidal ideation, self-injury, and aggression. These connections make sleep an essential screening target in every clinical encounter with autistic patients. Connective tissue and autonomic comorbidities form a second clinically important cluster. Hung and Margola's 2024 review in Nature Reviews Gastroenterology and Hepatology concluded that gastrointestinal dysfunction in autism isn't merely coincidental. Rather, it's associated with greater core autistic symptom severity and more psychiatric comorbidity, and it warrants proactive evaluation in patients presenting with feeding selectivity, behavioral escalation, or unexplained pain. Daylor and colleagues' 2025 global survey of 3,906 individuals with hypermobile Ehlers-Danlos syndrome, known as HEDS, or hypermobility spectrum disorder, documented a mean diagnostic delay of 22 years and a mean of 24 comorbid conditions per participant. These figures show just how chronically under-recognized this cluster is in adult medicine. Crompton and colleagues' 2026 study in BMC Medicine found that autistic adults with HEDS, or hypermobility spectrum disorder, reported more symptoms and poorer physical and mental health than non-autistic adults with the same connective tissue diagnoses. That confirms the conjunction isn't merely additive but multiplicative. Dysautonomic management principles articulated by Mathias and colleagues remain the standard framework for autistic adults with postural orthostatic tachycardia syndrome, or POTS, or broader autonomic dysfunction. These principles include increased fluid and salt intake, compression garments, trigger avoidance, and targeted pharmacotherapy when symptoms are disabling. Adding further depth to the picture of physical health risk, Pugh and colleagues' 2025 analysis in BMC Medicine examined 659 cognitively able autistic adults from the UK Biobank. They identified 3 disease trajectory clusters predisposing to excess mortality: cardiometabolic conditions, external causes, and infectious disease. Racial and ethnic disparities in cardiovascular metabolic conditions persist within the autistic Medicaid population as well, serving as a reminder that equity gaps compound clinical risk. These findings set the stage for the mortality data we'll discuss later in this module. But first, let's turn to the mental health picture. Now let's examine co-occurring mental health conditions across the lifespan. The DSM-5-TR states that approximately 70% of autistic individuals have at least one co-occurring mental disorder, and roughly 40% have 2 or more. This places psychiatric comorbidity at the center, rather than the periphery, of autism clinical care. Underwood and colleagues' Welsh population record study quantified the magnitude of this issue in adults. They found depression in 25.9%, anxiety in 22.4%, psychosis in 18.3%, attention deficit hyperactivity disorder, or ADHD in 7.0%, schizophrenia in 5.2%, obsessive-compulsive disorder, or OCD, in 3.0%, and bipolar disorder in 2.5%, with rates roughly 8 to 11 times higher than in the non-autistic population across all of these diagnostic categories. Torenvliet and colleagues' 2025 cohort found that 45% of autistic adults met criteria for a mood disorder, 22% for an anxiety disorder, and 21% for a personality disorder, at rates 6 to 34 times higher than among non-autistic comparators. The umbrella review by Kernow and colleagues highlighted both the wide variation of prevalence estimates in the literature and the near-total absence of interventions adapted to and tested in autistic adults. This is a gap that allied health clinicians encounter every time a mental health referral is made, without any confidence that the receiving clinician has autism-specific preparation. Sex differences in mental health outcomes are substantial and demand clinical attention. Martini and colleagues' 2022 analysis in JAMA Psychiatry examined 20,841 autistic Swedish young adults and found that 77% of autistic females and 62% of autistic males received at least one psychiatric diagnosis between the ages of 16 and 25. Compared to non-autistic same-sex peers, autistic females had roughly 3 to 20 times the risk of receiving each psychiatric diagnosis, and autistic males had roughly 3 to 19 times the risk, underscoring just how dramatically the psychiatric burden is elevated in this population. Psychiatric hospitalization was substantially more common in autistic females, at 32 per 100, compared to autistic males, at 19 per 100. Mental health challenges frequently emerge or escalate in adolescence. Adolescent onset or worsening mental health difficulties are reported by most families of autistic teenagers, with very few able to access beneficial professional support. This pattern is consistent with the broader service cliff that we'll discuss in detail in Module 7. Kenworthy and colleagues' 2026 longitudinal analysis further established that executive function challenges, particularly flexibility deficits, persist regardless of cognitive ability and are potent predictors of anxiety, depression, and aggression. Autistic females are at unique risk for escalating anxiety during adolescence, a topic we'll also explore further in Module 7. Diagnostic overshadowing is a critical concept for clinicians to understand. This term refers to the tendency for clinicians to attribute symptoms of a co-occurring condition to the primary diagnosis of autism, thereby missing the co-occurring condition entirely. Kentrow and colleagues' 2024 study in eClinical Medicine found that only about half of autistic adults agreed with their co-occurring psychiatric diagnoses, suggesting that autistic characteristics are frequently mislabeled as other psychiatric conditions. The DSM-5-TR advises that observable behavioral changes, such as changes in sleep, eating, or escalating challenging behavior, should prompt formal evaluation for anxiety and depression. This is particularly important for individuals with communication differences for whom a traditional self-report psychiatric interview may be inaccessible. When it comes to treatment of co-occurring conditions, clinicians should reserve pharmacologic treatment for co-occurring conditions and specific target symptoms, not for core autism itself. The 2023 Cochrane review by Ifland and colleagues reported that atypical antipsychotics, specifically risperidone and aripiprazole, probably produce a large and clinically meaningful reduction in irritability, supported by moderate certainty evidence. These medications may also produce a very large reduction in self-injury, though supported only by low certainty evidence, meaning these results should be interpreted with caution. In contrast, antidepressants showed no clear efficacy for irritability in autistic patients, and metabolic adverse effects of atypical antipsychotics demand vigilant monitoring. On the psychosocial side, Pomovska and colleagues' 2024 systematic review and meta-analysis found moderate certainty evidence supporting adapted cognitive behavioral therapy for anxiety in autistic individuals within collaborative care frameworks. Lay and colleagues' foundational 2020 synthesis in the Lancet Neurology established the broader principle that autism-adapted psychosocial support, which attends to sensory environment, communication modality, and predictability, is a core ingredient of effective mental health care across the lifespan. Now let's turn to one of the most clinically urgent issues in autism across the lifespan: suicide and self-harm risk. Suicidality is frequently the proximal precipitant of adult evaluation and of clinical contact in allied health settings. O'Halloran and colleagues' 2022 systematic review and meta-analysis reported pooled prevalence of suicidal ideation at 25.2%, meaning roughly 1 in 4 autistic individuals report suicidal thoughts, with estimates across studies ranging from about 1 in 5 to 1 in 3. Suicide attempts were documented at 8.3%, with considerable variation across studies reflecting differences in how attempts are measured and in which populations are studied. Suicide deaths were documented at 0.2%, a figure that, while numerically small, represents a disproportionate toll relative to general population rates. Self-report consistently yielded higher estimates than parent report across these studies. Population-level data further clarify the scope of this risk. Lai and colleagues' 2023 population analysis, published in JAMA Network Open, examined Ontario data encompassing 75,926 self-harm events and 66,938 suicide deaths. After accounting for neighborhood income, rurality, intellectual disability, and psychiatric comorbidity, autism was independently associated with an 83% increase in self-harm risk among females and a 47% increase among males. Elevated suicide death risk was largely mediated by psychiatric comorbidity, such that controlling for psychiatric diagnoses attenuated the effect, substantially in males and partially in females. The Global Burden of Disease 2021 Autism Spectrum collaborators estimated roughly 13,400 excess suicide deaths globally among autistic people in 2021, which represents about 1.8% of all suicide deaths worldwide. This figure tells us that the public health footprint of autism-related suicide is considerably larger than any single national cohort conveys. Our understanding of why autistic individuals face elevated suicide risk is advancing. Camouflaging, lack of support, psychiatric comorbidity, perceived burdensomeness, thwarted belonging, and the greater lifetime trauma together account for much of the elevated risk in autistic populations, particularly among late-identified adults and among gender-diverse individuals. Clinically, the Westby and Coburn-Pierce Primary Care Review emphasizes that suicide is the most common cause of premature mortality among autistic adults without intellectual disability, with risk estimates 2 to 10-fold those of the general population. Screening for suicidality should be deliberately incorporated into every clinical encounter, rather than deferred to specialty mental health services. Protective factors are empirically supported. Informal social support from family, peer connection, a sense of belonging, and autism-adapted access to care are repeatedly identified as resilience resources. Wolpe and colleagues' 2025 qualitative synthesis of autistic young adults transition recommendations emphasized acceptance, honest communication, and family support for executive functioning as practical levers that families and clinicians can mobilize. For allied health clinicians, the implication is straightforward. The presence of autism is itself an independent risk factor for elevated suicide risk that warrants explicit screening at every clinical encounter, a low threshold for referral, a safety plan conversation that accommodates communication differences, and, critically, careful management of the co-occurring depression, anxiety, epilepsy, and sleep disturbance that mediate much of the excess risk. Now let's examine the data on premature mortality and life expectancy. Autistic people die earlier than their non-autistic peers, and the mortality gap has been reproduced across jurisdictions, datasets, and decades. Catala-Lopez and colleagues' 2022 systematic review and meta-analysis published in JAMA Pediatrics examined 154,238 individuals across 12 studies and reported an overall all-cause mortality rate more than twice that of the general population, a finding that was highly statistically reliable and consistent across the studies examined. Autistic males died at roughly twice the expected rate, and autistic females died at nearly 5 times the expected rate, revealing a disproportionate mortality burden borne by autistic women that was consistent across multiple datasets. Death from natural causes occurred at nearly 4 times the expected rate, and death from unnatural causes, including accidents, suicide, and homicide, occurred at roughly 2.5 times the expected rate, with both findings showing strong statistical reliability. External causes were the leading underlying cause of death among autistic youth and young adults. More recent studies add important detail to these mortality findings. Onions and colleagues' 2024 United Kingdom matched cohort study estimated that autistic adults without intellectual disability lose approximately 6 years of life expectancy, specifically 6.14 years for men and 6.45 years for women. For those with co-occurring intellectual disability, the loss is even more dramatic at 7.28 years for men and 14.59 years for women. The authors noted that the diagnosed cohort likely overrepresents those with greater support needs because an estimated 9 in 10 autistic adults in the United Kingdom remain undiagnosed. Shaw and colleagues' 2026 analysis, published in JAMA Pediatrics, examined CDC autism and developmental disabilities, monitoring data on 23,393 autistic individuals identified at age 8 and followed through age 29. They reported an overall 35% increase in the risk of death, a finding that was statistically reliable and consistent with the mortality pattern documented in other cohorts. The risk for autistic females with co-occurring intellectual disability reached roughly 5-fold, meaning these women had about 5 times the risk of death compared to non-autistic peers. Cause-specific risks were also striking. Nearly 9-fold for epilepsy-related death, nearly 3-fold for cardiac arrest, and roughly 4.5-fold for COVID-19, with all three showing strong statistical confidence that the increased risk is real. Here's the critical takeaway for allied health practice. Modifiable contributors dominate the mortality signal, and this is precisely where allied health practice can make a real difference. Epilepsy death, cardiometabolic disease, suicide, accidental injury, which includes drowning, suffocation, choking, accidental poisoning, and medication side effects, and delayed presentation for acute medical care together explain the bulk of the excess risk documented in the major studies by Catala-Lopez, Onions, and Shaw. Bew and colleagues' 2025 disease trajectory clustering study reinforces that cardiometabolic external and infectious disease clusters predict excess mortality in cognitively able autistic adults, and that proactive management of modifiable cardiometabolic risk, including weight, blood pressure, lipids, glycemia, and activity, is a realistic clinical target. The Westby and Coburn-Pierce primary care review emphasizes injury prevention, including Heimlich training for caregivers of autistic children with feeding difficulties, epilepsy optimization, medication safety reviews, and explicit attention to healthcare access. This emphasis on access is critical because autistic adults often present later in the course of treatable disease. For healthcare professionals across rehabilitation and nursing disciplines, the practical message is the same across all settings. Recognize autism as an independent mortality risk factor, screen systematically for the modifiable contributors, coordinate proactively with primary care, and document accommodations needed for hospital and urgent care encounters, so that the next clinician doesn't have to rediscover them during an acute event. This proactive, coordinated approach is how we begin to close the mortality gap for autistic individuals across the lifespan. Module 6 brings us to the intervention evidence base, one of the most consequential areas for everyday clinical practice. With the diagnostic, sensory motor communication, and co-occurring condition evidence established in modules 1 through 5, we now turn to what the research says about interventions, beginning with early childhood and moving through school age. This module is titled Lifespan Interventions, Early Childhood Through School Age, and it covers the full range from early intensive behavioral approaches to naturalistic developmental behavioral interventions, to parent-mediated models and participant perspectives on applied behavior analysis, to AIRS sensory integration, and finally to school-age educational supports, school-based therapy, and school nursing. Let's begin with the earliest and most intensively studied intervention category. Early intensive behavioral intervention, commonly abbreviated EIBI, grounded in applied behavior analysis, has been the most extensively studied early intervention for young autistic children. Eldervik and colleagues' 2026 individual participant data meta-analysis, sometimes called an IPD meta-analysis, synthesized 15 studies involving 341 children receiving EIBI and 280 comparators, all between ages 2 and 6 and treated for at least 12 months. That analysis reported moderate to large improvements in adaptive behavior, large improvements in intellectual functioning, and very large reductions in autism severity. Roughly 1 out of every 4 to 7 children receiving EIBI achieved clinically significant change, which translates to a meaningful treatment yield in practical terms, and treatment intensity was a significant predictor of benefit within the IPD model. However, Eckes and colleagues' 2023 meta-analysis published in BMC Psychiatry reached a more tempered conclusion, finding medium improvements in intellectual functioning and small to medium improvements in adaptive behavior, both just reaching statistical significance versus minimal or no treatment, but no significant improvements in language, symptom severity, or parental stress. All studies in both meta-analyses carried serious risk of bias due to the absence of random assignment. The foundational lifespan synthesis by Lai and colleagues reinforces that the quality of evidence for early intervention as a whole remains constrained by methodological limitations rather than by sample size. Turning now to the question of intervention intensity, the historical recommendation of 20 to 40 intervention hours per week isn't supported by current evidence. Sandbank and colleagues' 2024 meta-analysis, published in JAMA Pediatrics, broadly failed to find significant associations between intervention amount and outcomes for language and social communication across behavioral and naturalistic developmental behavioral interventions. The only adequately designed randomized comparison of intensities, which compared 15 versus 25 hours per week over 2 years, found no significant differences in autism severity, expressive or receptive language, or nonverbal ability. The clinical implication is that intervention intensity should be individualized based on the child's needs, the family's capacity, and the specific treatment goal rather than prescribed by a uniform number of hours. This is a shift that has direct consequences for insurance authorization, caregiver burden, and school-based service planning. For allied health clinicians counseling families, this evolution in the intensity literature changes the conversation from how many hours can you get authorized to what goals will we target, with which modality, and how will we measure progress. That orientation is more consistent with outcome-driven rehabilitation than with accumulated service hours. Now let's look at naturalistic developmental behavioral interventions, commonly known as NDBIs. These include the Early Start Denver Model, or ESDM, Joint Attention, Symbolic Play, Engagement and Regulation, or JASPER, and Pivotal Response Treatment, or PRT. NDBIs integrate behavior analytic principles with developmental science in naturalistic, child-led settings. Project AM, the landmark synthesis by Sandbank and colleagues published in 2023 in the BMJ, synthesized 252 studies with 13,304 participants and reported significant positive effects of NDBIs in randomized trials, with the strongest improvements in social communication and diagnostic characteristics, moderate gains in adaptive behavior and play, and smaller but still meaningful gains in language. When the analysis was restricted to the most methodologically rigorous studies, only the NDBI effect on diagnostic characteristics retained statistical significance, showing a small to moderate improvement that just cleared the threshold for a reliable finding. That finding sharpens rather than dismisses the evidence base. The JAMA review by Hirota and King reported consistent findings, with small effects for language, small to moderate effects for play, and moderate effects for social communication. For minimally speaking children, Pope and colleagues' 2024 systematic review and meta-analysis of NDBIs combined with aided augmentative and alternative communication, or AAC, reported notably larger language gains when AAC was incorporated rather than withheld. The 2025 American Academy of Pediatrics clinical report by Desch and colleagues reinforces that providing AAC doesn't impede natural speech and may in fact promote verbal expression. The convergent message for allied health teams is that NDBI is the most studied early intervention framework with the broadest evidentiary support for social communication and diagnostic characteristic outcomes, and that AAC should be integrated from the outset for children with minimal speech rather than reserved as a last resort. Shifting now to parent-mediated intervention, this is the dominant model for scaling evidence-based early autism care, and its supporting evidence is now extensive and long-term. The Preschool Autism Communication Trial, known as PACT, is the first randomized trial to demonstrate sustained symptom reduction from a parent-mediated social communication intervention at long-term follow-up. Increased child communication initiation during treatment has been shown to mediate a substantial proportion of the follow-up effect on autism severity. Across contemporary network and pairwise meta-analyses, parent-mediated NDBIs, particularly pivotal response treatment and the Early Start Denver model delivered by trained caregivers, are associated with improvements in social communication, language, and caregiver intervention fidelity. Parent participation in early intervention during the preschool years consistently predicts more positive adult outcomes in long-term cohort follow-up. The foundational Lord and colleagues' 2018 Lancet synthesis established parent involvement as one of the most reproducible predictors of favorable early intervention trajectories. The American Academy of Pediatrics framework supports family-centered, coordinated early intervention as the standard of care for children under age 5 with suspected or confirmed autism. At the same time, the evidence base around traditional high-intensity applied behavior analysis, or ABA, and the lived experience of autistic adults who received it is now a core part of the clinical conversation. Anderson's 2023 qualitative analysis of autistic adults' recollections of ABA documented traumatic memories, perceived ethical violations, and explicit recommendations that practitioners listen to autistic perspectives and consider alternatives. Aguirre Matanus and colleagues' 2026 analysis of 17,120 autistic youth, matched with 17,120 controls in a United States national insurance claims dataset, found that ABA receipt was associated with a 30% increase in the odds of mental health hospitalization, a finding that reached statistical significance, although no relationship between ABA dosing and documented post-traumatic stress disorder or suicidality was detectable within the claims data. Project AM explicitly noted that adverse events in autism intervention research are poorly tracked, and that potential benefits can't be weighed against potential harms until monitoring improves. The Westby and Coburn-Pierce Primary Care Review acknowledges increased reports of post-traumatic stress disorder symptoms and mental health issues related to camouflaging among autistic adults who receive traditional ABA, which the authors flag as a clinical risk to weigh against expected behavioral gains. For allied health practice, these findings don't mandate a single prescriptive answer, but do require informed, family-centered counseling. This means presenting ABA, NDBI, and developmental options alongside the benefits and the emerging concerns, so that caregivers can consent to an approach aligned with their values and their child's characteristics. In practical terms, clinicians should be prepared to explain the evidence base and the identified risks for each approach, to respect family-level decisions that weigh cultural, logistical, and developmental factors, and to coordinate across providers so that a child receiving ABA, NDBI, parent coaching, and occupational therapy isn't subject to contradictory behavioral expectations across settings. Let's now turn to AIR sensory integration, commonly abbreviated ASI, which is delivered with fidelity, meaning adherence to the defined intervention protocol. ASI is now supported by strong evidence for individual goal attainment and occupational performance in autistic children ages 4 through 12. Acuna and colleagues' 2025 systematic review published in the American Journal of Occupational Therapy synthesized 5 randomized controlled trials, 4 at level 1B, of ASI delivered with fidelity. The review concluded that evidence is strong for improvements in individualized goal attainment and occupational performance, and moderate for daily living, self-care, social, communication, and play skills. ASI is not a treatment for behaviors of concern such as non-compliance or irritability, and shouldn't be positioned as one. Scharf and colleagues' 2025 comparative trial of occupational therapy using ASI versus ABA versus no treatment over 31-hour sessions found significant gains on individualized goals in both treatment arms over no treatment, with comparable improvement between ASI and ABA. This is evidence that ASI is a credible goal-directed alternative for families and teams weighing options. Sciano and colleagues' 2026 feasibility trial of a telehealth-adapted ASI intervention reported high parent and interventionist satisfaction, measurable improvements in individualized goals and functional skills, a decrease in autism symptomatology, and maintenance of fidelity. This is evidence that the access barriers to ASI may be more tractable than historically assumed. The Patton and colleagues' 2024 American Occupational Therapy Association practice guidelines endorse multidisciplinary, goal-oriented occupational therapy intervention supporting access, inclusion, engagement, and participation in meaningful occupations across the lifespan, with ASI among the evidence-based approaches available within the practitioner's toolkit. For early childhood and school-age occupational therapy, the practical implication is that ASI belongs in the recommended intervention conversation alongside NDBI, parent coaching, and school-based participation supports, and that it must be delivered with fidelity by trained practitioners rather than diluted into generic sensory activities. We now move into the school-age period, where autism persists in the large majority of children diagnosed in early childhood, and where comorbidity is the rule rather than the exception. Brignell and colleagues' 2022 Cochrane meta-analysis of 34 studies encompassing 11,129 participants reported a pooled persistence rate of 92%, a figure that was highly consistent across the studies reviewed. Valicenti McDermott and colleagues' 2023 school-age analysis found that 96% of autistic children had at least one co-occurring condition, most commonly language disorder at 91%, attention deficit hyperactivity disorder at 42%, intellectual disability at 25%, anxiety at 20%, specific learning disorder at 19%, and depression at 6%. Epilepsy remains a substantial concern, particularly among school-age autistic children with co-occurring intellectual disability, where prevalence reaches 21%. The educational scaffold for this population in the United States is the Individualized Education Program, or IEP, recommended by the American Academy of Pediatrics and the American Academy of Family Physicians, and typically incorporating coordinated behavioral, speech-language, occupational, and physical therapy services. Section 504 plans are available as an accommodation framework for students who don't meet IEP eligibility. Within the classroom, evidence-based practice use is uneven. Locke and colleagues' 2022 analysis of teacher and paraeducator behavior found that reinforcement strategies are nearly universal, used by 97.7% of educators surveyed, while peer-mediated interventions and video modeling, both with strong evidence, remain underdeployed because training and familiarity are limited. Structured educational approaches such as the treatment and education of autistic and communication handicapped children model, known as TECH, which is characterized by structured work routines and visual presentation of learning tasks, remain established components of classroom-based practice and are widely integrated with IEP goals and related services plans. School-based occupational therapy using ASI principles is increasingly positioned as an intervention that occupies the occupational therapy scope across all tiers of multi-tiered systems of support, as articulated in Whiting and colleagues' 2025 call to action, published in the American Journal of Occupational Therapy. Hilton and colleagues' 2023 analysis identified sensory processing, emotional regulation, behavioral variables, and social variables as the strongest predictors of participation, difficulties in autistic children, showing that participation-focused occupational therapy goals, rather than decontextualized sensory activities, are the priority target. School-based physical therapy addresses gross motor skills, balance, coordination, and fitness within tiered service delivery models that are increasingly implemented alongside special education services. Adapted cognitive behavioral therapy is supported by randomized trial evidence demonstrating significant symptom reductions for anxiety and depression in school-age autistic children and is widely regarded as a primary treatment option. Finally, let's consider the role of school nurses, who are integral to the multidisciplinary team. School nurses support medication administration, coordinate management of comorbid conditions, communicate across families and clinicians, and monitor for emerging medical and behavioral concerns during the school day. Dixon and colleagues' 2025 commentary published in JAMA Health Forum articulates the critical role of school nurses in children's health and education. Andre and colleagues' 2024 integrative review of nursing strategies for autistic children and adolescents identified 4 core domains: structured communication, collaboration with parents, and flexible use of sensory tools, environmental preparation and time management, and ongoing nursing education. These nursing functions intersect directly with the comorbidity profile of school-age autism. Epilepsy management, sleep and anxiety monitoring, gastrointestinal symptoms tied to selective eating, and monitoring for behavioral signs of pain or distress in children with communication differences all sit at the school nurse boundary. In combination with occupational therapy, physical therapy, special education teaching staff, and consulting physicians, school nursing closes the loop between medical, educational, and family systems that's indispensable to a coordinated school-age autism plan. School nurses provide the continuity of observation that allows subtle deterioration to be noticed before it becomes a clinical emergency. Module 7 carries us into adolescence and adulthood, where we shift our focus to transition planning, employment, healthcare access, and the autism-affirming frameworks that tie all of these together. If the earlier modules showed us what we know about identification, assessment, and intervention, this module asks a harder question. What happens when the autistic person grows up? And do our systems actually keep pace? Let's begin with the heightened clinical demands of adolescence itself. Adolescence is a period of heightened clinical vulnerability for autistic individuals. During this stage, the convergence of pubertal neuroendocrine change, persistent executive function differences, identity formation, and the emergence or escalation of psychiatric conditions creates clinical demand that frequently outstrips available services. Research by Corbett and colleagues on developmental cortisol patterns has demonstrated that autistic youth show a shallower diurnal cortisol slope and elevated evening cortisol relative to typically developing peers. Autistic females in particular exhibit higher cortisol levels, flatter slopes, and higher evening cortisol than autistic males. These hypothalamic pituitary adrenal axis, or HPA axis, findings align with the observed vulnerability to depression during puberty. Parent-reported data likewise indicate that pubertal sensory change itself, not simply age or autism severity, affects the developmental, interpersonal, and managerial domains of the transition to adulthood. Despite the clinical salience of this period, occupational therapy practice surveys have found that fewer than a quarter of practitioners routinely address puberty-specific challenges such as menstruation, personal safety, and sexuality, even when the same practitioners are already addressing emotional regulation and hygiene. Executive function challenges persist well into young adulthood. A 2026 longitudinal analysis by Kenworthy and colleagues, drawing on 313 autistic individuals aged 2 to 25 years across 941 observations, with a mean IQ of 103.3, found that flexibility, working memory, and inhibition deficits persist regardless of cognitive ability. Flexibility deficits were particularly potent predictors of anxiety, depression, and aggression. Depressive symptoms rose with age, and autistic females were at unique risk for escalating anxiety across adolescence. A 2025 qualitative study by Mukherjee and Beresford of 33 parents of autistic teenagers aged 15 to 19 found new onset or worsening mental health difficulties in most families, and very few had been able to access beneficial professional support. This is consistent with the broader service cliff that characterizes adolescent and young adult autism care. Adding another layer, a 2025 interview study by Drapalik and colleagues of autistic, female and gender-diverse adolescents established that camouflaging, while enabling social acceptance, produced identity confusion, internalized distress, and deteriorating mental health. This is a pattern that obliges clinicians to weigh the near-term social benefits of camouflaging against its longer-term mental health cost when setting goals with adolescent patients. Now let's turn to educational and healthcare transition planning. The Individuals with Disabilities Education Act, or IDEA, requires transition planning to be incorporated into the Individualized Education Program, or IEP, by age 16, with some states mandating earlier initiation. The American Academy of Pediatrics, or AAP, recommends initiating planning even earlier, between ages 12 and 14, to allow for adequate preparation. A 2023 population-based cohort analysis by Hughes and colleagues of 322 adolescents born in 2002 reported that 92% had an IEP with a transition plan by ages 15 to 16, but significant disparities existed. Adolescents without co-occurring intellectual disability were more likely to have competitive employment and post-secondary goals, and none of the Black adolescents in the cohort have received school-based mental health services compared with 28% of the overall sample. A 2024 follow-up analysis by Hughes and colleagues of 1,787 adolescents confirmed wide variation in services across geographic region, sex, intellectual ability, and race and ethnicity, with attention deficit/hyperactivity disorder rates of 47% and anxiety rates of 39% among enrolled adolescents. Rue and colleagues' 2023 Autism Transitions Research Project capstone review identified early engagement in transition planning, strong family and community support, equitable service access, and self-determination skill building as the consistent predictors of positive transition outcomes. And Wolpe and colleagues' 2025 qualitative synthesis of autistic young adults' recommendations emphasized acceptance, honest communication, and family support for executive functioning as practical levers. The analogous construct in healthcare is the transition cliff, which refers to the abrupt discontinuity that autistic youth experience in moving from pediatric to adult services. This discontinuity is associated with increased unmet medical need, decreased treatment adherence, and higher rates of preventable emergency department use. The AAP, the American Academy of Family Physicians, or AAFP, and the American College of Physicians jointly endorse GOT Transition and its 6 core elements: transition policy, tracking and monitoring, readiness assessment, planning, transfer of care, and transfer completion and integration. A 2025 pilot survey by Zhang and colleagues of 180 autistic adolescents and young adults found that only 53.3% reported completing healthcare transition, at a mean age of 18.02 years. Only 40 had had transition discussions with their doctors, and rural youth face greater unmet medical and financial needs. National data show that only about 23% of autistic youth receive healthcare transition services, compared with roughly 50% of youth with other special healthcare needs, though these figures vary substantially by state and health system. Building on these healthcare transition concerns, the AAP's 2024 policy statement on alternative decision-making for youth with intellectual and developmental disabilities recommends considering the full spectrum of supports. These include supported decision-making, medical proxies, and legal guardianship, which are options that vary in form and availability by state, with the aim of selecting the least restrictive alternative. The American Occupational Therapy Association's 2024 practice guidelines align the occupational therapy transition role around individualized, strengths-based, neurodiversity-affirming interventions embedded in interdisciplinary teams, with physical therapy and nursing professionals contributing complementary expertise in motor function, health monitoring, and care coordination within the same interdisciplinary framework. Beyond the transition from pediatric to adult services, employment represents the next major challenge. Employment outcomes for autistic adults remain poor. Rue and colleagues' 2023 cross-system analysis estimated that only 1.1% of working-age autistic adults who need employment services actually receive them, leaving roughly 1.98 million without access despite vocational rehabilitation agency expansion. A 2025 analysis by Menezes and colleagues reported paid work participation of 22.01% among autistic adolescents compared with 49.38% among typically developing peers. Younger age, lower household income, co-occurring intellectual disability, and more severe autism were associated with lower odds of employment. IGST's 2024 synthesis estimates that among the roughly 2/3 of autistic adults with age-appropriate cognitive skills, about half are expected to attain a college education, but only 25% hold full-time employment. The evidence base for vocational intervention, however, is strong. Project Search with autism-specific supports is the most rigorously tested program in this literature and has produced competitive employment rates of 73.4% in a multi-site randomized trial versus 17% among controls. That's a more than fourfold difference, with 87% retention at 12 months and mean weekly hours and wages at clinically meaningful levels. Customized employment approaches have reported competitive integrated employment in more than 98% of participants in retrospective case series, though these figures likely reflect selection bias inherent in uncontrolled studies. Individual placement and support models have demonstrated roughly 1.6-fold higher competitive employment rates in meta-analytic syntheses. And pre to post programs such as Success and Peers for Careers have shown consistent gains in employment and employment related social skills. Workplace accommodations are consistently rated as important by autistic employees, yet are unevenly provided. A 2022 UK survey by Davies and colleagues of 181 autistic adults found that most regarded workplace adjustments as important, but many weren't receiving them, and the burden of identifying accommodation needs typically fell on autistic employees themselves. A 2023 comparison by Davies and colleagues of 225 autistic, 64 neurodivergent, and 64 neurotypical adults documented that autistic applicants felt compelled to hide autistic traits during hiring and feared disclosure-related discrimination, an access barrier that precedes on-the-job accommodation. A 2023 UK analysis by Petty and colleagues of 98 autistic employees found that reasonable adjustments improved well-being and productivity without detriment, were low cost, and were easily implemented. Effective accommodation domains mapped across the literature include sensory modification, such as quiet workspaces, reduced lighting, and minimizing distractions, schedule flexibility, such as flexible hours, remote work, and predictable duties, communication support, such as electronic communication, clear written instructions, and job coaches, interview modification, and strength-based job matching, together with autism awareness training for employers and co-workers. While employment barriers limit economic participation, healthcare access barriers limit physical and mental well-being. Adult healthcare access is the clinical rate-limiting step for much of the physical, mental, and mortality burden documented in earlier modules. A 2022 international survey by Doherty and colleagues of 507 autistic adults reported that 80% of autistic adults had difficulty visiting a general practitioner, compared with 37% of non-autistic adults. The highest rated barriers were deciding whether symptoms warranted a visit, at 72%, difficulty making appointments by telephone, at 62%, not feeling understood, at 56%, difficulty communicating, at 53%, and the waiting room environment, at 51%. Self-reported adverse consequences included untreated physical and mental health conditions, missed specialist referrals and screening, more extensive treatment or surgery due to late presentation, and untreated potentially life-threatening conditions. A 2024 Delphi study by Warriman and colleagues comparing 21 autistic adults and 20 primary care providers revealed a systematic perception gap, with providers rating barriers less negatively than autistic adults themselves, and produced 22 consensus recommendations focused on provider education developed collaboratively with autistic adults, supported preparation for appointments, and improved care continuity. Qualitative work by McLean and colleagues in 2024 further confirmed that patient-to-provider communication, sensory sensitivity, and executive function issues remain the most consequential barriers. Two operational frameworks dominate the current literature on autism-affirming healthcare. The first is the Aspire Autism Healthcare Accommodations Tool, or AHAT, which stands for Academic Autistic Spectrum Partnership in Research and Education. Developed through community-based participatory research, AHAT allows autistic patients to generate personalized accommodation reports. In a pre- and post-study of 259 autistic adults and 51 primary care providers, mean barrier scores decreased substantially after implementation, a statistically significant reduction, and more than 94% of patient participants found it easy, important, and useful, with 82% of providers rating it moderately or very useful. A 2026 study by Wood and colleagues combined AHAT with video modeling and behavior skills training, and demonstrated that the instructional package effectively taught autistic adults to communicate needs and request accommodations, with generalization to novel providers and maintenance after intervention was removed. The second framework is SPACE, which stands for Sensory, Predictability, Acceptance, Communication, and Empathy. Endorsed by the AAFP, SPACE provides the structural counterpart at the clinic and encounter level and overlaps substantially with trauma-informed care. In practice, autism-affirming clinical encounters lengthen appointment times, schedule visits at the beginning or end of the day to reduce waiting, use natural or dim light in examination rooms, offer pre-clinic visits, accept written communication during visits, and use plain, concrete language with explicit check-ins. These practices align with co-designed primary care recommendations from modified Delphi studies. Intersectional disparities layer additional risk onto this picture. Transgender and gender-diverse autistic adults are more than 10 times as likely to report mental health conditions and 6 times as likely to report self-harm relative to cisgender non-autistic adults. Black autistic adults have increased odds of admission for ambulatory care-sensitive conditions compared with white autistic adults. These are patterns that demand explicit clinician awareness rather than generic inclusivity statements. Let's now look at how interprofessional collaboration ties these threads together. Coordinated interprofessional models are the structural answer to the fragmented services that researchers like Doherty, Jang, and Hughes have documented. The medical home model, recommended by the AAP, is associated with an 86% reduction in unmet mental health need among autistic children and adolescents, one of the largest protective effects documented in the autism healthcare access literature. It's also associated with substantially lower difficulty getting needed mental health care, with roughly a 60% reduction and reduced emergency department use. Specialized adult primary care medical homes, such as the Center for Autism Services, Transition and Resources Model, known as CAST, have improved continuity of care and preventive service uptake in autistic adults, with the odds of receiving any preventive service roughly 10 times greater than in national Medicare-enrolled autistic comparators. Project ECHO Autism extends this reach through telementoring that connects community-based providers with interdisciplinary autism expert teams. A multi-site stepped wedge trial, which is a design in which clusters sequentially cross from control to intervention, reported a meaningful 9% gain in provider knowledge that was statistically reliable. Subsequent ECHO Autism adaptations, including LINKS, adult healthcare, and family navigation versions, have consistently improved provider self-efficacy and family access to services. Stanek and colleagues' Attain model, co-created with caregivers and providers, demonstrated feasibility and acceptability for integrated mental health screening and linkage in pediatric primary care clinics. Shared decision-making, however, remains under-practiced in autism care. Multiple studies have documented that clinicians who rate their own effort as moderate or skilled nonetheless fail objective measures of shared decision-making quality, making this a priority area for implementation. Nursing is central to this interprofessional infrastructure across primary care, school, hospital, and care coordination settings. But gaps are explicit. A 2023 training program by Gore and colleagues called MOSEC increased maternal and child health nurses' autism knowledge, self-efficacy, and confidence in identification and caregiver conversations. School nursing strategies identified by Andre and colleagues in 2024 centered on communication structure, collaboration with families, sensory supports, environmental preparation, and time management. A 2022 cross-practice analysis by Cashin and colleagues showed that nurses in dedicated intellectual disability and autism settings reported significantly higher preparedness, knowledge, confidence, and comfort than those in general practice, highlighting the value of targeted training pathways. A 2026 qualitative hospital study by Watson Grace and colleagues identified substantial barriers, including absent formal autism education, inflexible routine adherence, and reliance on security for behavioral escalation, alongside facilitators including experiential autism knowledge, caregiver involvement, and respectful engagement. The persistent absence of a specific American Nurses Association position statement on autism for the period 2022 through 2026 has been called out repeatedly in this literature as a field-level gap. To close this module, let's bring together the cross-cutting principles that unify the practice model. Trauma-informed care, anchored in safety, trustworthiness, choice, collaboration, empowerment, and cultural, linguistic, and gender competence is endorsed by the American Academy of Child and Adolescent Psychiatry and the AAP, and is consistent with the SPACE framework we discussed earlier. Neurodiversity affirming practice is explicitly endorsed by the American Occupational Therapy Association's 2024 practice guidelines, and has been rated highest by autistic adults in survey work on therapy adaptations. Culturally responsive practice has the strongest recent evidence base in a 2025 meta-analysis by Lee and colleagues of 24 studies of culturally responsive interventions for autistic children and families from minoritized backgrounds, which reported a large, positive, and statistically significant overall improvement, with particular benefit for social communication, child mental health, parent mental health, and intervention fidelity. Family-centered care, participatory research with autistic co-producers, and consensus structures such as the 2024 SAFE initiative, which stands for Supporting Access for Everyone, complete the cross-cutting framework. The SAFE initiative articulated a Neurodevelopmental Disabilities Healthcare Bill of Rights and evidence-informed principles that now orient contemporary autism care across physical therapy, occupational therapy, and nursing scope. For the interprofessional team, the implication is clear. Adolescent transition, adult healthcare access, vocational supports, and autism-affirming care aren't separate problems solved by separate disciplines. They're a single continuum whose coordination determines whether the evidence documented elsewhere in this course actually reaches the autistic person in front of the clinician. Thank you for completing this course. We will now review the exam questions to solidify your understanding. Question 1. The DSM-5-TR requires clinicians to specify severity for autism spectrum disorder based on which of the following? The correct answer is C. The degree of support the individual requires in daily life, rated separately for each symptom domain. Rationale. The DSM-5-TR requires clinicians to specify severity separately for each symptom domain, social communication and restricted or repetitive behaviours, on the basis of the degree of support the individual requires in daily life. Level 1 requires support. Level 2 requires substantial support. Level 3 requires very substantial support. The DSM-5-TR explicitly discourages imprecise functioning descriptors such as high functioning and low functioning. Question 2. According to a 2025 systematic review covering 19 studies and over 6,000 participants, which language form was preferred by more autistic adults? The correct answer is A, identity first language, meaning the phrasing autistic person. Rationale. The Schock and colleagues 2025 systematic review, covering 19 studies with a combined sample of 6,350 participants, found that more autistic adults preferred identity first language over person first language. The clinical recommendation is to ask each patient their language preference, honour it, and default to identity first language when preference is unknown. Question 3. A persistent positive result on the modified checklist for autism in toddlers, revised with follow-up, carries which of the following clinical implications? The correct answer is D. A 47% risk of an eventual autism spectrum disorder diagnosis and a 95% risk of any developmental disorder, warranting full developmental evaluation. Rationale. Children with a persistent positive screen carry a 47% risk of an eventual autism spectrum disorder diagnosis and a 95% risk of any developmental disorder. This means a positive screen, regardless of the ultimate classification, should trigger a full developmental evaluation rather than reassurance. Question 4. According to Pekoski and colleagues' 2025 analysis of over 32,000 autistic 8-year-olds, approximately what percentage met criteria for motor milestone delays? The correct answer is B. Approximately 71%. Rationale. Pekoski and colleagues' 2025 analysis of 32,850 autistic 8-year-olds found that 71.4% met criteria for motor milestone delays. Population-level estimates range from 35% to 88% depending on the measure. Yet motor differences remain dramatically under-recognised in clinical care, with only 31.6% of affected children receiving physical therapy services. Question 5. Which of the following best describes how autistic burnout should be managed in clinical practice? The correct answer is A. Reducing social and sensory demands, restoring access to special interests, and pacing participation rather than pushing for increased output. Rationale. Ali and colleagues characterized autistic burnout as involving pervasive exhaustion, social and occupational withdrawal, cognitive difficulties, and increased surfacing of autistic traits. Management requires reducing social and sensory demands, restoring access to special interests, and restorative routines, and pacing participation. These symptoms can be mistaken for depression, but respond to different supports. Question 6. A clinician is developing a mental health screening protocol for an autism-focused adult healthcare clinic based on the DSM-5-TR prevalence data for co-occurring mental health conditions in autistic individuals. Which of the following best represents the proportion of autistic individuals who have at least one co-occurring mental disorder? The correct answer is D. Approximately 70%. Rationale. The DSM-5-TR states that approximately 70% of autistic individuals have at least one co-occurring mental disorder, and roughly 40% have two or more. This places psychiatric comorbidity at the center of autism clinical care, not the periphery. Question 7. According to the Acuna 2025 systematic review, ERA's sensory integration delivered with fidelity in autistic children ages 4 through 12 has which level of evidence? The correct answer is C. Strong evidence for improvements in individualized goal attainment and occupational performance. Rationale. Acuna and colleagues' 2025 systematic review, published in the American Journal of Occupational Therapy, synthesized 5 randomized controlled trials and concluded that evidence is strong for improvements in individualized goal attainment and occupational performance, and moderate for daily living, self-care, social, communication, and play skills. ERA's sensory integration is not a treatment for behaviors of concern and should not be positioned as one. Question 8. According to the 2025 American Academy of Pediatrics clinical report, which of the following statements about augmentative and alternative communication is supported by evidence? The correct answer is B. Augmentative and alternative communication does not impede natural speech development and may promote verbal expression and vocabulary growth. Rationale. The 2025 American Academy of Pediatrics clinical report by DSM and colleagues explicitly states that augmentative and alternative communication does not impede natural speech development and may in fact promote verbal expression and vocabulary growth, with evidence supporting its introduction in children as young as 9 months. This directly refutes the persistent clinical myth that augmentative and alternative communication delays speech. Question 9. According to Catala-Lopez and colleagues' 2022 systematic review and meta-analysis of over 154,000 individuals published in JAMA Pediatrics, which of the following best describes the mortality risk among autistic individuals? The correct answer is B. The overall all-cause mortality rate is more than twice that of the general population, with autistic females dying at nearly 5 times the expected rate. Rationale. Catala-Lopez and colleagues' 2022 systematic review and meta-analysis of 154,238 individuals across 12 studies reported an overall all-cause mortality rate more than twice that of the general population. Autistic males died at roughly twice the expected rate, and autistic females died at nearly 5 times the expected rate. Death from natural causes occurred at nearly 4 times the expected rate, and death from unnatural causes at roughly 2.5 times the expected rate. Question 10. The SPACE framework for autism-affirming healthcare encounters, endorsed by the American Academy of Family Physicians, stands for which of the following? The correct answer is A. Sensory, predictability, acceptance, communication, and empathy. Rationale. SPACE stands for sensory, predictability, acceptance, communication, and empathy. Endorsed by the American Academy of Family Physicians, it provides structural guidance at the clinic and encounter level for autism-affirming practice and overlaps substantially with trauma-informed care principles. That concludes our exam review. Thank you for your careful attention to each question. We hope this course strengthens your ability to provide evidence-based, affirming care for autistic individuals across the lifespan.